Sajili?
Yes, sir.
You can listen now.
I can listen now.
Hi, Chetan.
Hi, sir. Hello. Good afternoon. How are you?
Very good, very good. हाँ, तो एक बार जल्दी से वो स्क्रीन शेयर करके देख लेते हैं.
जी सर.
तो मे बी चेतन आप कर लो पहले, फिर सजली करके कर देंगे. हाँ, ठीक है. एक बार बस स्लाइड शो में रन कर दीजिए. हाँ, ठीक है. आई थिंक बिल्कुल बिल्कुल हाँ हो रहा है. ठीक है. तो व्हाट आई तो इसमें ऑलरेडी हम लोग इस तरह से कर रहे हैं कि फिजियोलॉजी ऑलरेडी डिस्कस हो चुकी होगी. उस समय में हम लोग स्पेसिफिक इटियोलॉजी रिलेटेड चीजें डिस्कस कर लेंगे. आफ्टर दैट अप्रोच के बाद एक बार केसेस हम लोगों के जो स्टैंडर्ड 10 केसेस हैं वो डिस्कस करेंगे, जस्ट टू कोरिलेट दैट. सो इट विल जस्ट कीप ऑन कंटिन्यूइंग इन दैट फैशन. सजली आप एक बार दिखा दीजिए स्क्रीन का. ऑलरेडी डिस्कस हो चुकी होगी. उस समय हम लोग स्पेसिफिक इटियोलॉजी रिलेटेड चीजें डिस्कस कर लेंगे. आफ्टर दैट अप्रोच के बाद एक बार केसेस हम लोगों के जो स्टैंडर्ड 10 केसेस हैं वो
Can you see my screen?
Yes, your screen is there. Yeah. I think just एक बार रन कर दीजिए एक दो स्लाइड्स. हाँ, ठीक है. I think that's perfect. हाँ, ठीक है. सजली आपका हो गया. आपका एक मिनट इसमें दिख कैसे रहा है वीडियो पार्टिसिपेंट्स व्यू स्टैंडर्ड. ठीक है. म्यूट स्पॉटलाइट फॉर एवरीवन. ठीक है. सजली आपका थोड़ा सा ऊपर की तरफ जा रहा है वेबकैम, तो या तो उसको थोड़ा सा नीचे कर लीजिएगा बस. हाँ, ठीक है. हाँ हाँ, रिद्धि. हाँ, रिद्धि म्यूट है शायद. हाँ,
गुड आफ्टरनून सर.
हाँ, गुड आफ्टरनून. अब आ रहा है आपका. एक बार आप ट्राई करके देख लीजिए शेयर करके. ओके, ठीक है. हाँ, एक बार जस्ट एक दो रन कर दीजिए. ठीक है. ठीक है रिद्धि, आपका दिख रहा है क्लियरली. सो आई थिंक अब तो सारा हो ही गया. एक नेहा का और बचेगा. तो एनीवे, सो व्हाट वी विल डू नाउ इसकी अभी 240 है. सो यूट्यूब पे तो अनलिस्टेड वीडियो के तौर पे चल रहा है. बाकी वी विल लॉन्च प्रोबेबली अराउंड 255 के आसपास हम लोग इसको करेंगे तब तक. ठीक है, 255 के आसपास. थैंक यू.
हाँ बोलो. इंदिरा चौक थी के वी चौक आओ ने ई बाजू. ના 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 150 ફૂટ રિંગ રોડ ઉપર.
नेहा, नेहा.
Yes sir, am I audible?
Yes, you are audible now. एक बार शेयर कर लीजिए स्क्रीन जस्ट टू हैव अ लुक कि हाउ इट.
Yes.
So basically it will work like that कि there will be initial fundamentals, then XX DSD, XY DSD, a bit of over testicular DSD, then Neha is talking about clinical assessment, I am talking about overall assessment approach, then we will have the cases, फिर उसके बाद गुने वो रिद्धि वाला सजली वाला, and then yours.
So just a moment, I'm trying to share.
106 ने तो रजिस्टर कर लिया है अभी तक, तो अब देखते हैं।
ओपन ही नहीं हो रहा स्लाइड इस पे।
मतलब क्या हो रहा है? शेयर
सर एक्चुअली आई एम यूजिंग समबडी एल्सेस लैपटॉप, इसमें वो माइक्रोसॉफ्ट का एक्सेस नहीं दिखा रहा है, तो वो ओपन ही नहीं हो रही स्लाइड।
ओके, आप मेल कर दो हमको, या तो जिससे हम लोग यहाँ से करेंगे, फिर नहीं होगा तो।
या श्योर सर।
या वही वाला लगभग है कि उसमें कुछ चेंजेस हैं?
तो
हाँ,
चेंजेस किए थे एनिमेशन का जो
आप
ऑर्डर है।
भेज दीजिए इसको, फिर जल्दी से भेज दीजिए।
या श्योर सर।
जीशान, ये वही आपका फ्रेंड है जो? ही इज फ्रॉम बैंगलोर?
नहीं सर, he is from Karnataka.
ओके,
Uddhav is also from there.
ओके,
From iDSD.
ये वहाँ की मैसूर की हैं।
तो मिल गया आपको?
अभी देख रहे हैं। हाँ। किस वाले में भेजा है?
जीमेल।
नहीं, अभी तो नहीं आया।
अच्छा सर, रीसेंड कर। सर मेरा 4 बजे तक आएगा ना टर्न?
आपका तो हाँ, वो अप्रोच वगैरह सारे एटियोलॉजी वगैरह 4 के बाद ही होगा।
ठीक है सर, मैं तब तक ये इंस्टॉल करने की कोशिश करती हूँ मेरे इस लैपटॉप में भी। आपको भी मेल करती हूँ दोबारा से, या
हाँ, मेल आप कर दीजिए, जिससे वो बैकअप रहे।
जी सर।
ठीक 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 है नेहा। ओके ओके,
ओके।
तो वी विल प्रॉब्ली 2:55 पे हम लोग इसको रियल लाइव करेंगे, 3 o'clock एग्जैक्टली। तो तब वी विल इंट्रोड्यूस एवरीबॉडी एंड देन वी विल गो फ्रॉम देयर। हाँ,
ओके
ओके ओके ओके, बाय।
आरती। हेलो।
हेलो नेहा।
हाँ नेहा, शेयर हो गया आपका। हेलो।
So is it visible now?
यस यस, इट इज विजिबल, या फाइन,
Okay, sir.
परफेक्ट, ठीक है, ओके। रिद्धि।
यस सर।
हाँ रिद्धि, अभी चेतन का फोन आया था कि वो थोड़ा उनका इमरजेंसी पेशेंट है, तो पहले एक्स वाई कर लेंगे, एक्स एक्स के पहले।
ठीक है, ओके सर।
ओके ओके, तो आफ्टर फिजियोलॉजी वी विल डू द एक्स 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 वाई वाला।
ओके फाइन।
ओके ओके। Okay, so good afternoon, everybody. And thanks a lot for joining us on this very interesting program of iDSD, which is going to focus about disorders of sexual development, which is a very intriguing topic, a very interesting topic, which is often causing a lot of confusion with regards to evaluation and management. What we're going to do today is to cover the entirety of this complicated topic using specific modules. And we are joined by our team from across the country, which will be doing this. We have got Dr. Sajali Mehta, who is there currently at Pune in the Surya Maternity and Child Hospital. Sajali, welcome to you. Who will be covering about the specific management on that. Welcome, Sajali.
Thank you, sir. And good afternoon, everyone.
Yeah, good afternoon. And we've got Dr. Riddhi Patel, who is currently working at BJMC Ahmedabad, and she will be talking about XYDSD. Welcome, Riddhi.
Thank you, sir. And good afternoon, everyone, and welcome to today's fantastic discussion on DSD.
We've got Dr. Neha Agarwal, who is currently in the Himalayan Institute of Medical Sciences, Dehradun, and she will be talking about clinical approach to DSD, one of the most complicated topics that we'll discuss on. Welcome, Neha.
Good afternoon, sir, and thanks for the kind invitation.
And we've got Dr. Chetan, who is going to join us from Rajkot. He is from the Center of Pediatric Endocrinology and Diabetes at Rajkot. He'll join us later from there. We've got Dr. Prateek Sen, who is here at our center, who will be joining us. And throughout that, we'll try to discuss the entirety of DSD in that perspective. And we will like to keep it interactive. So if there are any questions you can put forward, if you're looking at that, there will be a question answer session, which is there, which you can really look at. And based on that, you can put any questions from that perspective in that regard. So that can be put on in that situation. So I think without wasting much time, we'll start off with the overall discussion about this particular interesting topic. And we'll try to cover the entire physiology, pathology, causes, approach, management, entirety in that regards. And we like to keep it all in the form of a case-based discussion. So we'll start off with this case, a 1-month-old child who was referred as disorder of sexual differentiation to us. And if we can look at it, there were some issues with regards to the atypicality of genitalia, was noticed to have PRADA4 at birth, had a palpable gonad, and somebody diagnosed it as XYDSD. Of course, if there is a palpable gonad and if there is no Mullerian structure, you will start thinking of XYDSD. Was given a course of testosterone and was managed like that. There was improvement in the phallic length and the child was counseled. The problem was that the child presented 5 years later to us with renal failure. So what went wrong out here? This is a case of XYDSD, and we'll discuss that one of the most important aspects to consider here is the possibility of a Wilms tumor gene defect, the WT1 gene, which basically can result in Fraser syndrome and Dennis-Strass syndrome. This highlights the importance of not only reaching at an etiological diagnosis of DSD, but also to go at more specific pointers and reaching the final diagnosis in that regard. So this happened to be a WT1 defect. So this shows how a proper evaluation becomes important. Now, the second case which I'm highlighting is another interesting case. This is again a run-of-the-mill case. So often what happens is that we try to go through the path of least resistance. Okay, this is the most likely diagnosis, we establish it. But we should go more deep into that. This was a day 3-year-old child with DSD, had palpable gonads, were not there. So this was PRADA4. So it was actually quite virilized, but there were no palpable gonads. So what does it mean, Prateek? So yeah, so it basically goes more in the favor of other form, the XX-DSD, and at that point of time, uterus was present. So now, Pawan, if you see somebody who has got no palpable gonad and has got uterus, I think you've got a clear-cut choice that this is a XX-DSD. And since the most common cause of XX-DSD is 21-hydroxylase deficiency, that's what was thought. And 17-OHP was diagnosed, which was slightly high, and a CAH was diagnosed. Now, what we really need to understand here is that this elevation of 17-OHP was not huge. It was only slightly elevated in that perspective. And gradually, the hydrocortisone was tapered over time. And still, the child had a normal level of 17-OHP. So what we are dealing with is something which is typically beyond what we call classically as congenital adrenal hyperplasia. And then this child, she was being managed outside. She was referred to us with complaints of delayed puberty around 13, 14 years of age. And then we asked one specific question which gave us the diagnosis. And what do you think would be the question, Pratik? Yes, so this is the other differentials of X6-DSD. This is not clearly congenital adrenal hyperplasia because otherwise the 17-OHP would have gone up. This level of 17-OHP is not huge in that perspective. So when we asked for a single question, was there virilization in the mother? The answer was yes, which basically confirmed that this was actually a aromatase deficiency. So what was happening is that because there was no aromatase, there was increased amount of androgens in the baby and the mother. So placenta also produces aromatase. So that's why mother also became virilized and baby also became virilized. Now that virilization issue is gone, but now the problem is because no estrogen is being produced, that's why she is having delayed puberty. So this is a classical example of how we need to go deep. So both the cases highlight that it's not just your job done that you diagnose, okay, X6, DSD, XY, DSD. You have to reach the diagnosis because there are multiple implications which are there with regards to DSD, which needs to be identified in that regards. So what we're going to do over the next 2.5 hours is to cover the entirety of this complicated topic, initially with regards to pathophysiology, then we'll discuss about classification, then we will move forward with regards to the overall approach to the pathway, and then we'll go forward. All of you are welcome to go to our website, learning.growsociety.in, from which we are webcasting this event, where we have got multiple options available for learning in the form of our master pediatric endocrine course over 18 months, covering nearly now 100 modules on everything related to pediatric endocrinology. So if you want to learn, you've got each and every aspect which is there, using videos, using text, pre-test, case scenarios, and everything available. We have recently launched a pediatric endocrinology for postgraduate program, which again is covering a number of learning modules specifically for postgraduates for a 3-year period. All of you can have a look at a book which is available, and along with that there we have the mobile application basically, which is covering in that perspective the various aspects of management of pediatric endocrine disorders, including the approach pathway, the management pathway, the personalized management care, and there are various ways you can use. It's a very intuitive form in terms of evaluating patients with different disorders of pediatric endocrinology. And these are available on Android and iOS. Without wasting any time, we'll focus on iDSD. So we will have different topics. We'll start off with the fundamentals as to what really is the process of sexual development. We'll then take forward the XY DSD, which Dr. Riddhi will talk about. Chetan will talk about XX DSD. We'll then go on to clinical approach, how to basically examine and make the diagnosis there. Then I'll talk a bit about the approach in terms of the evaluation. Dr. Sajali is going to then talk about the overall management, especially the gender assignment. And then Dr. Pratik will talk about gonadectomy, a very important issue, which we'll discuss on that regard. So we'll go from there. It's an interactive program. All of you are feel free, can put on questions. We'll intermittently break for questions after each session so as to allow the continuity to happen. So without wasting much time, we'll discuss about the fundamentals of sexual development. Now, what we need to understand is that all of us start from a unicellular stage. And from that unicellular stage, basically everything is gender non-dimorphic. So a single cell, of course, has no difference between male and female. From there, there is so much differentiation which happens in terms of sexual development, and this involves multiple steps. The first step is genetics, which determines the initial phase. Then we have the development of the gonads, testis or ovary. Then we have got production of the hormones, testosterone and estrogen, which then act on their receptors and then finally cause differentiation and finally development of gender identity. So the whole process of sexual development starts from genetics to gonadal development, hormonal production, hormonal action, and then gender identity. And each and every step can be defective in that regards. So we'll start off with the gonadal development. So what we know is that all the gonads, the adrenals and the kidneys develop from the urogenital ridge, which basically emerges by around 4 to 6 weeks of life. And from that, we have the gonad, the bipotential gonad, which can produce both ovary and testis, develops. and multiple enzymes pathways are responsible for that. There are CBX2, GATA4, which are important, but most important are NR5A1, and which are also involved in adrenal involvement, and WT1, which are involved in terms of the renal involvement. So the initial gonadal development depends upon a number of genes which also regulate the adrenal growth and the renal growth. So whenever you're looking at an individual who comes to you with an atypical genitalia, always consider the possibility of a problem in the adrenals and the kidneys, and that's a very, very important thing. The first case was a classical example of XYDSD who developed renal failure because of a WT1 defect. Now, once the gonad is developed, this bipotential gonad is exactly same with regards to both boys and girls, both for testis and ovary, and then these genes will interact further to make it mature. So NR5A1 and WT1 both are essential for both primordial testis and primordial ovarian development. But when we say they are more likely to be associated with XYDSD and not XXDSD, is a very, very simple fact to remember. XXDSD has to be an act of commission. You need to have some extra way in which androgen is coming, androgen is working more, while XYDSD will come basically when you have got an act of omission, in that you don't have the enough production of this in that regard. So there is a difference there. So if there is a gene defect, that will basically cause XYDSD but not XXDSD in that situation. So these two will then develop the gonad, and from there you have got the first factor, the SRY gene, which is there in the Y chromosome, which determines the development of testis. And this SRY gene along with NR5A1 will activate the major protestis gene, which is the SOX9. So basically the interaction of SRY and NR5A1 is essential for SOX9, and this SOX9 controls the entire testicular development, right from the Sertoli cells to the Leydig cells to the myoid cells. So all the testis is controlled via SOX9 in that situation, along with the role of FGF9. Now, if you do not have this SRY, the anti-testis or the pro-ovary genes will start to interact in that perspective, and that will have a role in that regards. So basically what happens is that there are anti-testis genes like DAX1 and FOXL2, which basically are responsible for ovarian development. And there is always a tussle going around in terms of the testicular gene and the ovarian gene, and this will result in ovarian development. Now, FOXL2 and SOX9 are the major determinants of whether that particular bipotential gonad will develop into a testis or a ovary. Conditions which are associated with greater amount of SOX9 expression, even in a XX individual, will result in testicular development. Higher FOXL2 and higher DAX1, duplication of DAX1 will basically present more in terms of our development of the ovaries rather than testis in that perspective. So now if we look at the overall process of the development, we'll go by male and female. So for male, we need to have the XY, then the testicular development, testosterone production, testosterone action, differentiation, and finally gender identity. And the whole process is linked with each other. So when we talk about testis, it is made up of number of cellular pathways, which basically include the germ cell, which is a big part of the testis. These germ cells basically are not produced in the testis. They actually come from the coelomic epithelium around 5 to 6 weeks, and then they migrate from there to go into the testis around 7 to 8 weeks. Then we have got the Sertoli cells, which start appearing by 7 to 9 weeks, which are the major determinant of a number of testicular functions, particularly the production of the anti-Mullerian hormone, which causes regression of the Mullerian structure and inhibin B. We have got the myoid cells, which are more like a supportive cell for testis around 8 to 10 weeks. And finally, the Leydig cells, which appear by 10 to 11 weeks, which produce testosterone, which causes development of the external genitalia, as well as the INSL3 or insulin-like factor 3, which causes testicular descent. So in a way, if you talk about sexual development, Sertoli cells and Leydig cells are important. If there are defects in the Sertoli cells, there will be no AMH. There will be a molecular structure which is there. If there is a Leydig cell problem, there will be difficulties in terms of development of external genitalia because testosterone is not there, or there will be issues of testicular descent which requires INSL3. Now, if we just talk about the testicular descent, and this is particularly important from an XY-DSD perspective, is that for testes to descend, there are two parts which happen. The first part is the abdominal phase, and that is largely regulated by probably a number of factors, including INSN3. This is intrinsic to the testis. From the inguinal, the abdominal phase to the inguinal phase, it is largely androgen dependent. So if there are problems in androgen synthesis or in terms of action, the testis will basically be inguinal. So if you have inguinal testis, it basically means that the testis is reasonably all right. It is able to produce maybe AMH and ISL3. The problem is mainly in terms of sterogenesis, which basically, as then Pratik will talk about, the risk of malignancy becomes substantially lower in that situation. On the other hand, if the testis is abdominal, it basically means that it is grossly dysgenetic. It is not even capable to descend from the abdomen, and which basically means that there is a high risk of developing a number of these complications, particularly malignancies, which will be likely in that setting. Very important to remember is how these hormones and these axes play off. Now, what we see clearly is that the LH will start appearing by around 12 weeks of life, because this is when the pituitary is going to get matured. The FSH will start peaking a bit later. But what we need to remember is that testosterone peaks much earlier. And this 8 to 12 weeks of gestation is absolutely vital for the testosterone action, because this is the time when you will need to have the labioscrotal fusion. If there is testosterone deficiency during this period, you will have hypospadia, the atypical genitalia. Testosterone deficiency beyond that period will basically result in micropenis, but not hypospadia. And what you're seeing out here is that this LH is not playing any role here. So what's controlling this testosterone? It's actually the HCG, which is coming from the placenta. So even if you have got no pituitary, no hypothalamus, no LH, you will still have a normal fusion, because placental HCG will take care of this 8 to 12 weeks. There would be micropenis which will develop, but not undescended testis, or not classically in the sense of hypospadia. So if you talk about hypogonadotropic hypogonadism, Kalaman syndrome, you would not have these problems which are happening in this situation, and this is extremely important from that perspective. Now, a word about testicular sterogenesis, because that's important from a clinical perspective for XY-DSD. The 7-DHC, which is the primary compound from which you have produced cholesterol using DHC, is the most important part. And from there, you will have this cholesterol, which is converted via a number of enzymes, cyclin cleavage, STAR, and 3-beta-HSD into progesterone. From there, you have got the testicular development. Many of these steroigenic pathways are shared by the adrenals as well as the testes. So defects in them will cause a salt wasting form of CAH along with a XY-DSD. Now this progesterone is converted via 17-hydroxylase into androstenedione, from there via 17-beta-HSD to testosterone. Testosterone is basically a pro-hormone. It has got an affinity for the androgen receptor, but the affinity is much higher for the dihydrotestosterone. And this is very, very important in the perspective of 5-alpha reductase deficiency. Now, what we need to understand is that you need to have much higher level of testosterone to have the same effect as that of a dihydrotestosterone. So in tissues which are very close to the testis, you will have a hugely high level of testosterone, like let's say the seminal vesicle, the internal structure, the Wolffian duct, And therefore, in 5-alpha reductase deficiency, where you are not producing dihydrotestosterone, there will be no problem in internal genitalia. While if we talk about penile growth, that is determined based upon systemic levels, and the systemic levels of testosterone will not be high. So therefore, 5-alpha reductase deficiency will predominantly present to you with external genitalia issues. And during puberty, once your androgen levels really go up, they will be able to act on the androgen receptor, and that will result in some virilization. So 5-alpha reductase is classically known as penis at 9 syndrome. And this basically is a situation wherein you will be born, the individual will be born basically with atypical genitalia, which will then virilize during puberty. And therefore, it would be imprudent to label them or raise them as a female, because you would expect that they would have had a good amount of exposure of androgens in the fetal period as well as during the mini puberty. So the programming of the centers which regulate gender identity will already have been happened, and during puberty again you will have an increased production, and that will again regulate in that perspective. And therefore this 5-alpha reductase deficiency should always be reared as a male in that perspective. If on the other hand you talk about androgen insensitivity, that will basically have no virilization at puberty, because the androgens are increasing but they will not act. In fact, they will feminize during puberty, because this androgen will be converted into estrogen, and that will cause more growth in that perspective. So defect anywhere at the DHC, which cause Smith-Lemeli-Opitz syndrome. These milder forms, the severe forms of C8, the side chain cleavage star, 17-hydroxylase associated with hypertension, 17-beta-HSD complete reversal, and 5-alpha reductase will all cause XY-DSD, and this is what will be discussed by Riddhi after this part in that regard. Now, DHT, as discussed, acts upon the androgen receptor, and then testosterone is aromatized to estradiol in that situation. As I discussed, testosterone will be converted via 5-alpha reductase into DHT, which then can cross into the cell and act on the androgen receptor, from where it goes into the nucleus. So it's basically an intracellular receptor which then acts on the nucleus like a transcription factor and regulates the production of different proteins. Now this testosterone can also act on this receptor, but its potency is much lower, and that's why in 5-alpha reductase you will have a lower production in the beginning, you will have lesser testosterone and more genital abnormalities. As puberty happens, the levels will soar and you will have an increased production in that situation. Now, in terms of the internal genitalia development, as discussed, they are all the same. So they are basically the Mullerian duct and the Wolffian duct. So if we talk about the development from the testes at 7 weeks, AMH will basically cause regression of the Mullerian structure. And then you have 8 weeks, you have got testosterone coming up, which is causing stabilization of the Wolffian structure. And this Wolffian structure will then result in development of the epididymis, vas deferens, and seminal vesicle. So the defects in testosterone production before 12 weeks of life will have a huge implication on both internal and external genitalia. Beyond 12 weeks, the only problem which will happen is in the setting of having a small phallic size or micropenis with a normal genitalia in that regards. So on that, what is happening is that this Mullerian structure is basically gone. Now we have got this Wolffian duct which develops into the epididymis, vas deferens, and the seminal vesicle, which progresses from there. Just a word about the female sexual development. It's often been said that the female development is more like a passive process, but it's not true. There are a lot of active genes which are also involved, and that's why we have got autosomal problems which also cause DSD. Yes, what we need to understand is that if you have an act of omission, the default development mode, so to speak, is a female. So if you have got a SRY gene deletion, if you have got a complete steroidogenic defect, if you have got a complete androgen insensitivity, the XY individual will develop into a female. Problems in ovarian development, estrogen production, estrogen action, they will all present with delayed puberty and primary amenorrhea, they will not present with DSD. So for XX DSD to happen, you need to have an active process which is there. Again, the female development involves the genetics, the gonads, the hormones, the receptor differentiation, and finally the gender identity. In terms of the hormonal development, if you look at it, what we see is that the levels are much higher in girls. So LH and FSH levels are very, very high, particularly around the preterm gestations, and they tend to be persistently high in that regards. What you need to understand here is that if you have got a preterm baby and you look at the levels at around 26-28 weeks of gestation, the LH FSH levels will be looking like menopausal. So you have to be cautious in evaluating these individuals. And one condition which is extremely common in that regards is the atypical clitoromegaly, which happens in the preterm newborn, which is more like a swelling rather than really a clitoromegaly. In that setting, if you do LHFSH, the levels may be falsely high, and that will cause confusion in that regards. And estrogen levels are of no relevance because the first antral follicle starts to develop just at term, and you will have some amount of estrogen at birth. So even if there is zero estrogen, there will be no disorder of sexual development in a XX individual in that regards. Now, ovarian steroidogenesis, the pathways are similar. So the same, we're talking about cholesterol, and from cholesterol, you've got this production of progesterone, which, as discussed in ovary, is by the theca cell produced into androstenedione, and then by granulosa cell into aromatase. So the same processes are involved in that regards. Defects in this synthesis pathway will not cause DSD. This is what I'm trying time and again. Unless you have androgen excess, you will not have a XX DSD. Of course, if there is a problem of aromatase, if the problem of 21 hydroxylase or POR, you will have more androgens, and that is going to cause a DSD in that situation. So this is how it works. And in terms of development, again, because there is no testosterone, the Wolffian structure will not be supported, and Mullerian duct will basically develop under these influences, and you will have other influences like WNT4. What's very important to remember is that Mullerian duct is responsible for the development of the fallopian tube, uterus, and upper third of vagina. So conditions associated with Mullerian agenesis or even complete androgen insensitivity may have a small vagina, because the lower vagina is not dependent upon this whole Mullerian structures. So even if your AMH is there, AMH is working, you may have a blind vagina which may be there in that regards. And this Mullerian structures are absolutely important to identify, because they will very easily help you classify the DSD into two. You look at basically gonads plus minus, Mullerian structures plus minus, and there are 4 big classifications coming up guiding how to investigate. Now, how do you look for these Mullerian structures? You can do a parectal examination using your little finger and feel for a resistance or an ultrasound. Now, what you need to understand is that the uterus is big at birth in girls because of the maternal estrogen exposure. So if you are not seeing a uterus, it usually means that it's actually an absent uterus, and it's not easy to miss it, so to speak, in that situation. Now, external genitalia development definitely, of course, involves mainly estrogenic exposure. If, however, there is more androgens, which they will cause more growth and clitoromegaly in that perspective. As for boys, there is no labioscrotal fusion after 12 weeks. So if you have a newborn who presented to you with PRADA 3, PRADA 4, with a labioscrotal fusion, you are dealing with basically a antenatal excess of androgens. If it's happening after 12 weeks, it will only cause clitoromegaly. And that's an important point to remember. Just as we were talking about how androgen deficiency before 12 weeks causes atypical genitalia, beyond 12 weeks will basically cause a normal genitalia with micropenis in that situation. The second major organ after the gonads in the entire axis is, of course, the adrenals, because this is an important source of androgens, and adrenals basically convert cholesterol, same pathway, to progesterone. And from there are 3 different pathways. The 11 hydroxylase will take it towards the aldosterone. 21 will take it towards cortisol, and 17 will take it towards DHEAS. So if there is a deficiency of any of these, if cortisol is less, you will have increased ACTH production and accumulation of all these compounds before the block, and that is going to cause a lot of problems and confusion in that perspective. So these are the reasons which we know as congenital adrenal hyperplasia, the most common cause of XX-DSD. Again, this is an act of commission in which you have got more androgens coming up. It is not an act of omission, to speak in that perspective. And this is how it progresses. And of course, a very important enzyme here is the POR, the oxidoreductase, which basically controls the three major enzymes, the 21, the 17, and aromatase. And POR deficiency will also cause a XX-DSD in that situation, in that perspective. So problems in 3-beta-HSD, they will cause salt wasting and DSD. Problems in 21-hydroxyl, salt wasting and DSD. 11 will cause hypertensive variant with DSD. Aromatase deficiency will cause normal salt status with DSD, and POR will cause salt wasting in DSD. So again, looking at the sodium status and looking at the DSD pattern, you will know which way to go forward in that regards. A couple of words with regards to the placenta. Placenta is a very, very important organ. It not only acts like a sieve of preventing the androgen exposure, it also is an active endocrine organ. So basically, the androgen and estrogen cannot cross the placenta because you've got 17-beta-HSD. So generally, maternal virilization will not cause fetal virilization unless the dose is huge. So if there is too much androgens, you're giving some medication which is causing that. Otherwise, the placenta is able to take care of it in that perspective. The other thing to remember is that this DHEAS, which is being produced in industrial amounts by the adrenal, cannot cross because this aromatase converts it into estriol. If there is aromatase deficiency, you will have more androgens, and that will cause the problem. Very importantly, we have still now talked more in terms of biological factors. There is also an identity issue. We need to understand what really is gender identity. So gender identity, gender role, and sexual orientation are three different things. Gender identity is what that particular individual identifies with, and this is the most important thing, because role will depend upon what society you are in, and orientation is of course a much more wider term in that perspective. The major determinant of gender identity is actually the androgen. So if there is a fetal androgen exposure like TRADA5-CAH, 21-hydroxylase, they would have a gender identity issue, and it is usually determined by 8 to 12 weeks of gestation. So that period is very, very crucial in that situation. So now once you've discussed everything, I'll just summarize to form the basis of other speakers to come in and chip in. So we've got the urogenital ridge from which we develop the gonads, and WT1 is also regulating the development of the kidneys. NR5A1 is developing the adrenals. Now, which produces DHEAS, which is causing the androgen exposure. We have got the testis, which is regulated via SRY and SOX9, and it is regulated via the LHCG receptor, in which the LH and HCG are both acting in that situation, which induce the Leydig cell producing testosterone, and which is converted via the 5-alpha reductase into DHT, which acts on the androgen receptor. We also will have the FSH angle acting via the FSH receptor on the Sertoli cells to produce AMH, which causes regression of the Mullerian structure. So both of these axes have a important issue, and we can understand that in that perspective. So if there is Mullerian structure which is present, it means that there is a total testicular failure. From the ovarian side, if there is a DAX1 FOXL2, that will produce the ovaries, and from there will be the theca cell production via the LH action, and FSH will induce the aromatase to produce estradiol, which will act on the estrogen receptor to cause increased uterine growth in that perspective. So this is the overall pathophysiological pathway, and if you have defects anywhere, you can have a problem in that regards. So problems can be at the level of gonadal development. There could be a problem in WT1, which causes XX-DSD, NR5A1, again XY-DSD, problems in SRY, XY-DSD, problems in SOX9 XYDSD, problems in DAX1. So again, duplication of DAX1 will cause a testicular regression, again a XYDSD, or you can have increased androgen production causing 21 hydroxylase deficiency, causing a XX-DSD in that regards. There could be problems in the ovarian axis, and what we need to remember is that it should not cause DSD unless there is a problem in the aromatase in which you've got more androgens, which is causing DSD with maternal virilization. And finally, this is a large chunk. There could be a problems in the development of the testis, hormone formation and action. So this could be a LHCG receptor defect, 5-alpha reductase defect, AMH defect, or the androgen insensitivity, and they will all cause XYDSD in that regards, and that will be important. So if you now classify DSD, it could be XX, in which there will be Mullerian structure but no gonads. The conditions basically will include androgen excess like 21, most likely 3-beta-HSD, POR, aromatase, luteoma of pregnancy, and ovarian tumor, very, very rare. Dysgenesis, in which you have got SRY insertion, which may happen, or SOX9 activation, and rarely RSPO1 and FOXL2. XYDSD, in which there will be a testis, but there will be no Mullerian structure in that setting. This includes dysgenesis like NRF51, WT1, SRY, DAX1, inefficient testosterone effect in the form of a LHCG receptor defect, teratogenic defects, 3-beta-HSD, 17-hydroxylase, and 3-beta-17-beta-HSD, 5-alpha reductase and AIS, and finally sex chromosome DSD, in which you can have a testicular DSD or you can have a over-testicular DSD in which you've got both ovaries and testis. This may represent a problem of mosaicism or chimerism. So we'll now be talking about individual these conditions. It looks very complicated and all these pathophysiology look complicated, but I'm sure things will become much more clearer now once we've got all these concepts in with regards to that. So we'll start off first with So I will start off with the XX-DSD, which Dr. Chetan will talk about. So Dr. Chetan, you are there?
Yes, I'm here and we can start.
Yeah, you start that then. Yeah.
Okay. So good afternoon, all of you, and I will be talking about the XX-DSD part. Is the screen visible?
Yes, it's visible. Yeah.
Okay, fine. So as Dr. Anurag has rightly said that the XX-DSD, the major issue is the androgen exposure. And also we know that the female genitalia and external female genital appearance is a default. If at all there is no ovary, then and then still it will be of female genitalia. So XX-DSD to happen, you need some androgen exposure to virilize that female genitalia. So any steroidogenic defect which will lead to excess androgen production via diverting the precursors from the zona glomerulosa and fasciculata to the reticularis will ultimately lead to high androgen in form of high androstenedione, and they will virilize the female genitalia by doing clitoromegaly, labioscrotal fusion, and they will give rise to the DSD in an XX genotype. Apart from this androgen exposure and high androgens, there are few genes which are responsible for the testis development. They might be inserted into that XX chromosome or an autosome, and they can also lead to the development of either ovotestis or a partly testis, resulting in an XX male, and this is also one of the causes of the XX-DSD. And in ovaries, we know that there are some anti-testis genes like R-sponding1 and FOXL2. So if these genes are deleted, then automatically, apart from the ovary, there is also development of a few tissues of testis which can produce testosterone, and this testosterone can virilize the external genitalia of female, giving rise to the ambiguous genitalia in an XX genotype. So most common is of course the steroidogenic defect, which will leading to the high androgen production, which will lead to the virilization of the female genitalia in utero. And as Dr. Anurag rightly said that labioscrotal fusion occurs by 12 weeks of intrauterine life, and after that there will be only clitoromegaly. There will not be any labioscrotal fusion. So in steroidogenic defect, we know that the zona glomerulosa produces aldosterone, zona fasciculata produces cortisol, and zona reticularis produces DHEAS, which will be converted to the androstenedione, which is a major androgen of ovarian origin. So any block in either cortisol pathway or aldosterone pathway, which will ultimately divert all these precursors to the last, that is zona reticularis, giving rise to the high androgens in intrauterine life. And we know that the most common defect, the 95% of the all steroidogenic defect in an XX genotype is 21 hydroxylase deficiency. And we know that this deficiency might be mild, moderate, or severe. And depending on this enzyme deficiency, either it will present as classical salt wasting, or a simple virilizing, or a non-classical CH. In classical salt wasting, the enzyme activity is less than 1% or practically undetectable. In simple virilizing, the enzyme activity is between 1 to 10 or 15%. And in the simple virilizing, the enzyme activity is approximately 20%. So depending on the quantitative 21 hydroxylase, it will present at different part of the life. So 21 hydroxylase will lead to salt wasting, but in an XX individual, it is caught before even salt wasting happens due to the genital atypicality or genital ambiguity. And in this, due to blockade at the 21 hydroxylase, the proximal metabolite, which is 17 hydroxyprogesterone, will be elevated in hundreds and 1,000 times more to the normal limit, and hence the 17 hydroxyprogesterone is a screening investigation of choice to detect the 21 hydroxylase, and it should be done only after 42 hours of life, preferably in the 3rd day of life, because of the normal surge in all hormones, same as the thyroid and other hormone occurs. The next most common, which is responsible for the 5% of the all XX DSD, is 11 hydroxylase deficiency. And we know that this 11 hydroxylase is present in again the cortisol pathway as well as aldosterone pathway. But though it blocks the aldosterone, the proximal metabolite, that is deoxycorticosteroid, is also a potent mineralocorticoid. And it is the reason that due to this high DOC level, the patient or the child will have hypertension. But in the initial 1 to 2 months of life, we know that there is mineralocorticoid resistance. So this 11 hydroxylase deficient child might also be presenting with the salt wasting variety earlier, followed by the development of the hypertension later in life. So hypertension again is a hallmark if the patient presents later in life, and 11 deoxycorticosterone level should be done if we are suspecting 11 hydroxylase deficiency. More proximal defect, that is 3-beta-HSD, and we know that the 3-beta-HSD is one of the most important enzyme because it affects all 3 pathway of cortisol, aldosterone as well as androgens. And we know that the adrenal gland comprises of 3-beta-HSD2, and we also have 3-beta-HSD1, which is present in the periphery, which is present mainly in the liver. So 3-beta-HSD2 deficiency in the adrenal gland will result in the excess DHEAS, and this DHEAS will go to the liver and it will be converted to the androgens via this 3-beta-HSD1, and ultimately they will virilize the female genitalia. So this is the mechanism where 3-beta-HSD2 deficiency will result in the female genital virilization. It will present as salt wasting, but this salt wasting might be delayed as compared to the 21 hydroxylase deficiency. And 17 hydroxypregnenolone is the investigation of choice for the screening of suspected 3-beta-HSD2 deficiency. Again, as earlier discussed, POR, that is oxidoreductase, which acts as an electron donor to the 3 enzymes, that is 21, 17 as well as aromatase, will lead to the mild salt wasting as compared to the classical salt wasting of 21 hydroxylase deficiency. And the ratio of 17 hydroxypregnenolone to the cortisol or to the 17-OHP, there are different cutoffs which are helpful to diagnose the POR deficiency. Again, aromatase is the same as POR, And we know that the aromatase enzyme is present also in the placenta. So aromatase deficiency will lead to excess androgen production even by the placenta, which goes to the mother. And these androgens can virilize the mother in pregnancy. So there is typical history of change in the voice, muscularity, excess hair growth in the mother, which simultaneously subside after the baby is born, is typical and characteristics of the aromatase deficiency. Now we know that the 21 hydroxylase deficiency is very common. It is seen in approximately 1 in 20 to 30,000 female live birth. And we know that the defect is at the level of 21 hydroxylase, and depending on the quantitative presence of this enzyme, it will manifest as either classical or simple virilizing, or non-classical, which is present as PCOD picture later in the post-pubertal life, in which there is low cortisol and low aldosterone, and manifest include prenatal virilization followed by the pigmentation, and salt wasting typically happens after second week of life, because we know that during first 2 to 3 weeks of life there is aldosterone resistance. So baby will not lose salt even if baby is absent or baby is deficient in the aldosterone level as well. 17-OHP is the hallmark, and we should send the 17-OHP whenever the patient presents with the atypical genitalia or in salt wasting crisis. And 17-OHP is usually more than 1000 nanogram per ml. And if the 17-OHP is borderline, then we should suspect other deficiencies like 3-beta or aromatase as well. 11-beta hydroxylase deficiency is observed in 5% of the total virilized female of the live birth. And we know that there is low cortisol but high mineralocorticoid due to excess DOC level. Again, due to the cortisol deficiency, there will be high ACTH leading to the pigmentation, and mild salt wasting can also be observed in the early first or second month of life, followed by hypertension in the later life. So hypertension along with hypokalemia with metabolic acidosis is the metabolic alkalosis is the hallmark of the 11 hydroxylase deficiency, and deoxycorticosterone is the investigation of choice. 3-beta HSD2 deficiency again can cause both. It can cause virilization in female resulting in XXDSD. It can also cause XYDSD because the peripherally converted androgens are not that sufficient to cause the normal development of the male genitalia. So 3-beta HSD2 deficiency can cause both XXDSD as well as XYDSD, in which defect is at the central level or more proximal level. But due to peripheral androgen production, the female genitalia will get virilization. Again, these children are also deficient in the cortisol as well as mineralocorticoid. So we should be supplementing them as soon as possible. Mild salt wasting, preferably majority of them are observed in maybe second month of life. And high 17-hydroxypregnenolone is the initial screening investigation of choice. Of course, there will be high DHEA because DHEA is just proximal step to the 3-beta HSD2 enzyme. So we can do DHEA to see whether they are high or not. And this can also give an idea regarding the possible 3-beta HSD2 deficiency. POR, that is cytochrome P450 oxidoreductase deficiency, is presents with the, of course, female genital virilization, but the function of this P450 oxidoreductase is to give electron donation to the other three enzymes, that is 17 and 21 hydroxylase along with the aromatase. So the deficiency of PR again depends on the quantitative, that how much this enzyme is deficient, and there is variable amount of 17-hydroxyprogesterone, 17-hydroxypregnenolone. So ideal is genetic investigation, though we can see the ratio of 17-hydroxypregnenolone to cortisol as well. Due to aromatase deficiency, there is also a history of maternal virilization, and mild salt wasting can be observed depending on the how 21-hydroxylase enzyme is deficient or not. High 17-OHP level is also observed because of this 21-hydroxylase is absent or very low in these individuals. Again, aromatase presents with the same, but the hallmark is high androgen even in the mother. So maternal virilization history is typical, and we should be asking whether there was any voice change, there was any hair growth during the pregnancy or not. and it is an early onset, and 17-OHP can be mildly elevated, not to the level of the 21, but yes, mildly elevation of 17-OHP as well as typical history of maternal virilization will probably point out towards the aromatase deficiency. And the aromatase deficiency is typical of high androgens in the intrauterine life, followed by estrogen deficiency, because we know that this aromatase enzyme converts all our androgens to the estrogen. So in the later life, there is a history of delayed puberty followed by the ovarian cyst due to faulty estrogen production and high androgen production. So early in life, virilization; later in life, estrogen deficiency, infertility, and delayed puberty is observed, and this is the typical of aromatase deficiency. So this is the table of steroidogenic defect which can lead to XXDSD and the female virilization. The most common is 21 hydroxylase. So of course, we should be doing 17-OHP hydroxyprogesterone as the first line investigation whenever we suspect the virilized female with absent gonads and Mullerian structures present on the ultrasound. Rest all are comprises of approximately 4 to 5%, so they are very rare. But still, if we found borderline elevated 17-OHP or the delayed salt wasting or with hypertensive virilized female, then we should suspect all other variants of the steroidogenic defect, and accordingly we should screen and investigate the child. Now, as I said earlier, that the XXDSD is an act of commission. We need something from outside in form of androgen to virilize that genital female genitalia. So sometimes it happens that maternal androgen can cause the virilization of the female fetus by crossing the placenta. So luteum of pregnancy and ovarian or any adrenal lesion on the maternal side can also lead to high androgen production in the mother, which crosses the placenta and virilize the female fetus. Danazol, of course, is a known to cause the female genital virilization, and there is a typical history of both maternal virilization as well as fetal virilization. So this is again a differential diagnosis to the aromatase deficiency, and it is generally a progressive virilization, and depending on the androgen exposure, the virilization extent is seen in the fetus. Now, if the ovarian antitestis gene are deficient, or any gene which can give rise to the testicular tissue development, it can also cause increased androgen production in that female fetus, and this can lead to the virilized female. Majority of them are having a part of testis gene, that is either SRY or any other distant gene, which lead to the development of fine testicular tissue along with the ovary, resulting in either ovotestis or dysgenetic gonad, which are able to produce some androgens which can cause female virilization. So NR5A1 again is responsible for the adrenal development as well as gonadal development. So any NR5A1 defect, or earlier called as steroidogenic factor defect, will lead to the XX ambiguity with adrenal hypoplasia. FOXL2 is an ovarian gene, so any, as well as it works as antitestis gene. So deficiency or mutation, inactivating mutation in FOXL2 can result in defective ovarian development followed by the increased androgen production. WNT4 and R-sponding1 gene are also classically required for the ovarian cell development as well as stroma development, and any mutation in this gene can also lead to the XX gonadal dysgenesis, resulting in the virilized female. So SRY transposition, we know that the most important gene in the testis development is of course SRY, which is normally present on the Y chromosome, but many times it happens that this SRY gene can translocate to either any X chromosome or any autosome, which can result in the production of the testicular tissue as well as the androgens. So SRY is the only one gene, so we do not have typical testicular development, but still there are some testicular tissues which can virilize the female and which can cause the issues regarding to the gender identity of the female fetus. So manifestation, again, SRY insertion are typically having some testis. There might be irregularly shaped testes which may be present in the abdomen or the inguinal canal or even in the testis, but these are dysgenetic gonad. They can produce some amount of testosterone but not the typical sperms and the semen in the this type of SRY transposition male, but still they are reared as a male. These are called XX male. Primarily they are infertile male because there is no development of the sperms, and this SRY gene induced androgens can inhibit the Mullerian structures. So there is no Mullerian structures. So phenotypically they are male, but genotypically they are XX. So they are called as XX male. NR51 mutation, again, as I told earlier, it is responsible for the adrenal gland development as well as testis development. So NR51 activation will lead to the development of the testicular tissue along with the excess androgen. And we know that homozygous NR51 mutation is typically leading to the XX male, but the parents of this homozygous NR51 are heterozygous, and accordingly counseling is required, genetic counseling. It is present generally in the 10 to 20%, and in this NR51 defect, if it is heterozygous, then adrenals are rarely affected. Only affected part is the gonads, and it will result in the XX male. SOX9 duplication will again lead to the SOX9 is a distal gene compared to the SRY. So SOX9 duplication will lead to the inhibition of the FOXL2, which is responsible for the ovarian development, and ultimately it will lead to testicular development, though karyotype is XX. So the patient might have a normal genitalia of a male with infertility due to absence of other genes like SRY and FGF9, which ultimately leads to the normal male fertility. So these are again XX male due to SOX9 duplications. SOX3 expression again, which will ultimately lead to its distant counterpart, that is SOX9. It will increase the expression of the SOX9, lead to either testicular development or over testicular development, and fertility is variable. But theoretically, it should not, the XX male due to a SOX3 expression should not be fertile. Now coming to the ovarian gene, which are responsible for the normal ovarian function, and these are WNT4 inactivating mutation, which will lead to defect in the ovarian development, which will lead to either defective ovary, that is streak gonad, or testicular development or ovotestis. And this WNT4, we know that it is required for the kidneys as well as lung development. So they might have multi-system involvement in form of either renal or renal and lung maldevelopment along with the XX virilized female counterpart. R-spondin1 is the one of the distal most genes in the ovarian development, and we know that the R-spondin1 inactivating mutation will lead to again the defective ovarian development, leading to the decreased estrogen production and virilization of the female fetus. The typical phenotypic appearance is either testicular or over-testicular DSD along with the palmoplantar hyperkeratosis. But sometimes, many times it happens that this R-spondin1 or WNT1 gene defect might get discovered at the later life whenever there is an infertility issue or delayed pubertal issue in the female, because many times it happens that if androgens are not there during the time of the intrauterine life, then this might be born as the normal female, but ultimately they will be infertile or there might be delayed puberty as well. So these are the genetic defects. Ultimately, they will be infertile whether they are raised as male or a female, because they have not the proper list or proper array of genes which are required for the normal gonadal development and normal gonadal function. So again, XX-DSD is an act of commission. We need some androgen to virilize the female genitalia. So either they can come from the fetal adrenal or fetal ovary, or from the mother, or from the drugs. And they can present at birth in form of atypical or ambiguous genitalia, or they can present at delayed puberty or even infertile woman as well. So with this, I would like to rest my talk, and thank you all, Dr. Anurag and his team, for giving me this opportunity. So this was all about the XX-DSD, and I hope all have understood the XX-DSD well. Thank you. Over to you, sir.
Thanks a lot, Chetan, for this wonderful talk. And we've discussed about, very importantly, the various aspects of X6-DSD. While we all understand that 21-hydroxylase deficiency is the most common, there are many more factors which have to be looked into, as we discussed in the second case. This could be aromatase deficiency, or now we're discussing the evolving genetic role. Thanks a lot, Chetan, for this wonderful talk. We will now move forward to the next aspect, which is the XY-DSD, which, as we've been discussing, may actually be an act of omission. So even if you have no normal development, there would be a DSD which is going to happen. And for that, I like to invite Dr. Riddhi Patel, who is currently working as in DJMC Ahmedabad, and she has just been a fellow recently, and she'll talk about XY-DSD, which has been quite a complicated topic in that regard. Over to you, Riddhi.
Thank you, sir. Is it visible, sir? Okay, so today I'm going to discuss about the XY disorder of sexual development. Though it includes a wide range of the disorder, but after understanding of extensive physiology, pathophysiology by Dr. Anurag, now I think it will become easy. So XY disorder of sexual development occurs because of the defect in either gonadal development or testicular development, or because of the defect in gonadal function. That includes either impaired testosterone synthesis or its excess. And the disorder of sexual development caused by the impaired gonadal development include the various genetic defects, and that this includes the common one is the SRY deletion, though it is not as common as that is seen in XX female, but still it accounts for 10 to 20% cases. And SRY deletion can cause complete sex reversal with complete female appearance, and they present with the or they can present with a variable form of genital ambiguity, or it can be because of the early genetic defect like NR5A1, which is involved in adrenal development also. So it is associated with adrenal insufficiency, or they present with isolated XY-DSD, or WT1, which is involved in renal differentiation plus differentiation of bipotential gonad into testis. So it is associated with renal abnormality in form of the mesangial sclerosis or congenital nephrotic syndrome, or very severe in form of Weger syndrome. It can also be caused by the distal genetic defect like SOX9, which has mainly role in Sertoli cell development, and it is also involved in skeletal development. It is associated with campomelic dysplasia, skeletal dysplasia, and or it can be because of the involvement of the other ovarian gene, which is actually anti-testis gene, but if they are duplicated in XY individual, it will cause regression of the testicular tissue, and they present with the DSD. Now, most of this form of the genetic defects are associated with abnormality or variable abnormality of the Sertoli or Leydig cell, and they have variable presentation. So they have very heterogenic presentation. If it is very mild genetic defect, they just present with the micropenis, hypospadias, bifid scrotum, and genital ambiguity. If it is partial genetic defect, then they have combined Sertoli and Leydig cell function defective. So they will present with DSD plus some amount of the Mullerian structure may be there. And if it is complete, then there is a defective Sertoli, Leydig as well as germ cell function. So they present with complete female, normal female with strict gonads, and they are the differential of the primary amenorrhea. So we'll discuss each and every defect in detail. So SRY deletion, which is accounts for 10 to 20% cases of the XY gonadal dysgenesis, and they have presentation in form of either genital ambiguity to complete sex reversal. They can also present with ovotesticular DSD, and they have highest risk of malignancy. So gonadectomy is essentially in the early stages of life if we identify this defect earlier. NR5A1, as it is also involved in adrenal development plus bipotential gonad development, it is if it is homozygous defect, it associated with combined adrenal and gonadal dysfunction. So they have adrenal insufficiency plus XYDSD, and if it is heterozygous defect, they just present with isolated XYDSD. And NR5A1 has also role in ovarian development. So as Dr. Chetan has discussed, it can also cause XXDSD. And manifestation include mainly in form of the genital ambiguity and adrenal insufficiency. They have low level of the testosterone because NR5A1 is also involved in Leydig cell function and testosterone synthesis. They can also cause ovotesticular DSD, and the presentation is similar like partial androgen insensitivity. Both the conditions should be differentiated, and confirmatory test is genetic testing. Because the management is different. For NR5A1, they respond to testosterone, while partial AIs do not respond to testosterone. They need higher doses of testosterone for the management. So differentiation is essential in such cases. WT1 is involved in renal development plus differentiation of bipotential gonad. So its abnormality are associated with renal abnormality, and the defect may be variable in form of deletion, duplication, mutation, and their manifestation includes various syndromes. This includes the Dennis-Diss syndrome if it is associated with mesangial sclerosis, Frazier syndrome if it is associated with congenital nephrotic syndrome, or if there is continuous gene deletion, then they can present with severe form of Weger syndrome. This includes the Wilms tumor, aniridia, genitourinary abnormality, or mental retardation. Now, it is important to identify WT1 abnormality in XYDSD because it needs the lifelong surveillance for the renal abnormality and renal function. As sir has discussed, already discussed in first case, that baby just presented with XYDSD, but when we did genetic analysis, it came out to be WT1 defect. So this cases require the surveillance for renal function. It is essential to identify this defect. Now, SOX9, as I said, it is involved mainly in Sertoli cell development, but their presentation is variable, and it is also involved in growth plate development. They present with skeletal dysplasia, and that is mainly campomelic skeletal dysplasia. So it is considered in individual with DSD and skeletal dysplasia. Now, DEX1, it is mainly involved in ovarian development, but it has also role in adrenal development plus gonadotroph development in pituitary. So, duplication of DEX1 can present with XYDSD along with, sometime it may present with adrenal insufficiency and hypogonadotropic hypogonadism in later life because its role in gonadotroph development. So, all of these genetic defects, if we summarize, then WT1 defect is associated with renal abnormality, NR5A1 is steroidogenic defect and adrenal insufficiency, SRY is complete sex reversal, and it one of the common cause of the XYDSD. DEX1 duplication can also cause sex reversal, and it may associated with adrenal and pituitary involvement, and SOX9 defect is associated with skeletal dysplasia. So if these are the associated feature, we should think of the gonadal dysgenesis because of this genetic defect, and genetic analysis is required in such case. These cases are generally infertile, they don't have preserved fertility, and all these cases should be reared as male because of the some form of the the gonadal tissue is there. If there is there, then they should be reared as men. Now, XY female is actually the domino. They are the complete female, but they have they present with generally primary amenorrhea. So they are like differential of the Turner syndrome, but their height is normal or even high on the higher side because of the Y chromosome, and they have gonadal failure. So they present with hypergonadotropic hypogonadism. And it occurs because of the various genetic defect like SRY, NR5A1, CBX2, and management is same like Turner syndrome, but they need gonadectomy because of the highest risk of the gonadoblastoma because of Y chromosome material. Now, anorchia is actually the intrauterine vascular event which leads to the regression of the testicular tissue, and if this event occurs before 6 weeks of life, By that time, even Sertoli cells are not functioning. Then both Mullerian structures are present and gonads are not there. Means testis is not working. So they present with the complicated form of DSD plus presence of Mullerian structure. But if this event occur after the 6 weeks of life, then generally Mullerian structures are absent and their presentation is like genital ambiguity with no palpable gonads. So, and these gonads are generally absent. So, for identification of gonads, sometimes people are doing laparoscopy before doing the biochemical analysis. So, we should do the AMH and inhibin B before doing laparoscopy. If this metabolites of AMH and inhibin B are undetectable, it suggests that testicular tissue is not there and it does not require the laparoscopy. Now, persistent Mullerian duct syndrome, it is actually not DSD, but it is put here because it is associated with the impaired gonadal function. So here there is defect in AMH production or AMH exon. So AMH gene or its receptor is defective, and that's why there is persistence of Mullerian structure. The external genitalia are normal because testosterone synthesis is normal actually, but the gonads are actually not palpable, or they may be higher in the abdominal region, and that is because of mechanical issue, trapping of these gonads in somewhere in the Mullerian structure in between fallopian tubes. So they have undescended testes. Now, after discussing these various genetic defects, which are the causes of XY gonadal dysgenesis, now we will move towards the various steroidogenic defects, which will cause a low level of androgen production and presence with XY DSD. And this includes, the first one is the DHC, which is required for conversion of the 70 hydrocholesterol to cholesterol. And cholesterol is the first precursor which is required for synthesis of all the metabolites or all the adrenal hormones, that includes the aldosterone, cortisol and androgen. And it is associated with the Smith-Lemli-Opitz syndrome. So they have low level of the androgens, aldosterone, cortisol, everything is low. So they present with salt wasting, or if the defect is mild, they just present with DSD and some syndromic features like upturnness, syndactyly, cardiac defects. Lipoid congenital adrenal hyperplasia occurs because of the early enzymatic defect of the star and side chain cleavage, which is required for the transfer of cholesterol to mitochondria and the first step of the conversion of cholesterol to pregnenolone. So if this defect occurs, they have low level of all the metabolites, so they have salt wasting. But as Dr. Chetan has discussed, that this salt wasting is generally delayed because there is destruction of the steroidogenic cells of the adrenals. So salt wasting is generally delayed, and they present with XY-DSD. 3-beta hydroxysteroid dehydrogenase, which can cause XY-DSD as well as XX-DSD, as discussed in earlier session, and it will also cause salt wasting if it is complete 3-beta HSD deficiency. But the onset of salt wasting is delayed by around 2 to 3 months of age. The 17 hydroxylase, which is required for the 17 hydroxylation of pregnenolone and progesterone plus further conversion of this 17 compound to the androgens. So if it is defective, it is associated with XY-DSD plus the precursor before this are accumulated, which is diverted to aldosterone synthesis. So they have accumulated aldosterone, and they present with hypertension with XY-DSD. Now, other distal enzymes which is required only for androgen production. This includes the 17-beta HSD3, which is required for conversion of androstenedione to testosterone. If it is defective, they present with complete lack of testosterone, so that they have complete female appearance, but they virilize during the puberty because of action of this androstenedione to on androgen receptor. And other defects of the testosterone action, that includes the 5-alpha reductase 2 or androgen receptor defect, they also present with XY-DSD. But here adrenal function is normal because there is no affection of the aldosterone or the cortisol. Now we will discuss all the enzymatic defect in detail. Now the LHCG receptor, which is the receptor which is shared by both LH and HCG for the functioning of the Leydig cell. So if this receptor is defective, then neither LH nor HCG can act on the Leydig cell to produce testosterone. So there is DSD, XY DSD, and depending upon the severity of the defect, they have variable presentation in form of genital ambiguity to the complete sex reversal. Biochemical presentation is in the form of low testosterone, high level of LH, because LH is not working on receptors, so it is accumulated, and a normal level of FSH. And actually, one of the important differential is there is no rise in testosterone level after HCG stimulation. So, which is also one of the diagnostic tests to identify HCG receptor defect. Now, DHC7 receptor defect, this is caused by the defect in DHC7, and there is reduced cholesterol plus Leydig cell hypoplasia, and they have syndromic features in form of upturned nose, rotated ears, or microcephaly, syndactyly. So it is considered when there is DSD with adrenal insufficiency, with or without adrenal insufficiency, and syndromic features. Or in every case of XY-DSD, always look for syndromic features to identify the DHC7 defect, and they may be suspected if there is high level of the 7-DHC. Lipoid CAH, that is because of the star or side chain cleavage defect, which is mainly required for the earlier reaction, and that is conversion of cholesterol to pregnenolone. So they are associated with adrenal insufficiency and XY-DSD, and they have a variable form of the salt wasting also, and all the metabolites are low, and there is no response to synectin. 3-beta hydroxysteroid dehydrogenase 2 is mainly required for conversion of the progesterone to pregnenolone to progesterone, 17-hydroxypregnenolone to 17-hydroxyprogesterone, and DHEA to androstenedione. So it is required for synthesis of the all, that is aldosterone, cortisol, as well as androgen. So in the defect of 3-beta HSD2, there is low level of androgen. So there is XY-DSD, plus there is salt wasting because of lack of the aldosterone plus cortisol. If the defect is milder, then they present with just XY-DSD without salt wasting, and it can be suspected if the DHEA level is high. Now, 17-hydroxylase defect, as I discussed earlier, that there is defect in cortisol as well as androgen synthesis, but because of the accumulated precursors are diverted to the aldosterone synthesis, they have hypertension and hypokalemic metabolic alkalosis. So the XY-DSD with hypertension, this is 17-hydroxylase defect, and if there is XX-DSD with hypertension, then it is 11-hydroxylase defect. It is diagnosed by doing the metabolites of deoxycorticosterone or corticosterone. Now, 17-beta HSD3, which is required for conversion of androstenedione to testosterone, so it is testosterone synthesis enzyme. If it is defective, it is associated with complete sex reversal. So there is complete female appearance, but there is virilization of the genitalia during puberty because of action of androstenedione on androgen receptor, and it can be diagnosed by using this ratio of testo to androstenedione. If it is less than 0.8, it suggests 17-beta HSD3, so it is not reliable test. A genetic test is the final diagnostic. Cytochrome P450 oxidoreductase, which is electron donor, which is required for the 3 enzymes, that is 17-hydroxylase, 21-hydroxylase, and aromatase. And in its defect, there is XY-DSD or XX-DSD plus salt wasting, and variable presentation can be there. It can also present with just delayed puberty and hypogonadotropic hypogonadism. They also virilize during the puberty, and they can be suspected when there is elevated level of 17-hydroxyprogesterone and progesterone. So the steroidogenic defects which are associated with XY-DSD includes the DHC7 star and side chain cleavage and 3-beta HSD, which are the earlier defects. These are associated with the also impaired adrenal function. So there is salt wasting. 17-hydroxylase defect is associated with hypertension, while distal defects of 17-beta HSD3 is associated with normal adrenal function, and just XYDSD, incomplete sex reversal. POR, the presentation is variable. They have even salt wasting or isolated XYDSD. Now, after discussing this various abnormality which are associated with the defect in testosterone synthesis, now we will discuss the defect in testosterone axon. So 5-alpha reductase 2 enzyme, which is required for the activation of the testosterone. So testosterone is actually pro-hormone which need to be activated to DHT for its action. As sir has discussed that in fetal life, because of the testosterone level around the Mullerian duct is very high. So, around the Wolffian duct is very high because they are locally produced. So, internal genital development is normal. But as the DHT is required for external genital differentiation and it is not synthesized in 5-alpha reductase 2 defect, so they have genital ambiguity with normal internal genitalia, and AMH is working well, so there is normal Sertoli cell function, so they don't have Mullerian structure, and it is suspected when the testo to dihydrotestosterone ratio is more than 10. This we can use basal or even HCG stimulated, but this is also not reliable test. Genetic test is the final diagnostic. And androgen insensitivity, where there is problem in androgen receptor itself. So androgens are there, but they are not working, and depending upon the severity, if it is complete, they present with complete normal female, and they present with primary amenorrhea, normal breast development, but sparse pubic hair. They have a hypogonadotropic hypogonadism and XY karyotype. If it is partial, they present with genital ambiguity, and if it is very minimal or mild defect, they just present with infertility or gynecomastia. Inefficient androgen axon, there are mainly two defects, 5-alpha reductase 2 and complete AIS. If we differentiate them, so the main defect in 5-alpha reductase 2 is testosterone activation, while complete AIS is associated with defect in testosterone action. T-DHT ratio is high, more than 10 in 5-alpha reductase 2 defect, while it is less than 10 in complete AIS. At puberty, 5-alpha reductase 2 defects are virilized because of the action of the high level of testo at puberty on the androgen action, but they generally feminize because testo is not working on androgen receptor, but the high level of testo get aromatized in peripheral tissue, and that will cause breast development in complete androgen insensitivity patients. Gender of rearing, preferably male in 5-alpha reductase 2 defect, while it is female in AIS. And Mullerian structure are absent in both the condition because Sertoli cell function is normal, AMH functioning is normal. And management is mainly with dihydrotestosterone in 5-alpha reductase 2 defect, while complete AIS, as we are rearing them and as female, they should be treated with the estrogen, and gonadectomy should be done if they are abdominal gonads. Now, various drugs, use of various drugs in mother can cause DSD because of the disruption of the various endocrine pathway, and this includes the use of diethyl stilbestrol, phenytoin, or phenobarbital can cause DSD, and they, depending upon the dose and duration of exposure, they have variable phenotypic presentation in form of mild genital ambiguity or complete female. And if we do the analyze such patient with the various endocrine metabolites, they are normal, so it should be suspected when there is everything is normal, still DSD, and if there is history of use of these drugs in mother. So with this, I would like to stop my discussion, and will further take the sex chromosome DSD, which will be covered by Dr. Neha. Thank you.
Thanks a lot, Riddhi, for this wonderful presentation. And I'm sure a lot of you would be boggled upon with so many information which is there, starting from physiology to XY, XYZ. But we had to lay all the foundation because it's very, very important to understand that. There is some issue with regards to the questions. We're not able to receive the questions. So what we have done is that our tech team is working on the question issues, and hopefully will be sorted out. So all of you can maybe put it towards the end, and we will take it up on that. We will let you know once it starts working from there. So what we'll do now is that we will move forward to the further aspect of The DSD, so we've discussed about X6 DSD, XY DSD. We'll now have a bit of a word with regards to the 6 chromosome DSD. And this is going to be much smaller because this is one area which is small but very confusing. So when you say 6 chromosome DSD, it's a term which has now been used more often, especially after the DSD classification, the newer classification which came up into the fact, and it actually includes terms like Turner syndrome and Klinefelter syndrome. Now those should not ideally be considered as DSD, because when you say Turner syndrome, the diagnosis itself excludes atypical genitalia in that regard. So when you talk about 6 chromosome DSD, in our perspective from a clinical situation, we are talking about situations in which you either have got a mosaicism of X and Y or a chimerism, and both of them will have a difference. So what is the difference between mosaicism and chimerism? So when we say mosaicism, it is a post-zygotic defect. So in post-zygotic defect, what's basically happening is that you have got one cell line which is having a normal cell type or a different cell type, and the second one is a different cell type. So it's a post-zygotic, and the manifestations will depend upon which particular cell types are affected and which cell types are expressed in different areas. When you talk about chimerism, it basically means the two cells have fused so that you've got an extra chromosome, and that causes confusion in that regard. So we'll go one by one. So one common presentation here is a XXY mosaicism. So you should not confuse this with Turner syndrome. Many of girls with Turner syndrome will be X0 and they may have XY, but they would be phenotypic female. That's very, very important message out there. The defect here is post-zygotic. It will be variable. So depending upon which cells have got X0 and which cells have got XY, you may have development of one particular gonad in one area, the other in the other area in that perspective. So gonad usually would be a normal or a dysgenetic testis and a normal and a dysgenetic ovary. So depending upon where you have XX, you will have a different. X0, you will be like a Turner syndrome like presentation, and XY will have a testicular development which happens. And of course, streak gonad may happen if it's a X0. The features are that, of course, if you have one particular area behaving like testis and one particular area behaving like ovary, they will be genital asymmetry. So if you have got a asymmetrical genetic appearance, always consider the possibility of a XXY mosaicism, which becomes important. And as Pratik will discuss later on, they have a huge malignancy risk, and this is something which we need to be really bothered about, because this Y chromosome can cause a problem. The other thing to remember is that if you have mosaicism, depending upon which one is predominating. So if you have a predominant Y mosaicism, this will behave like a male appearance, and then they may develop feminization. So they may develop suddenly gynecomastia. So if you have unexplained feminization at puberty, start thinking of a XY mosaicism, which is predominant. If you have a predominant XO with a XY which is minor, they will present as a normal looking female also with virilization. So during puberty, if you have feminization or virilization, start thinking of these funny things. Of course, besides the AIS, besides the 5-alpha reductase in that regards. Now, many of these features, if you have X0, effectively will behave like Turner syndrome. Now, what really is Turner syndrome? Turner syndrome is the deficiency of the pseudo-autosomal genes. So if the same genes are defective, you may have short neck, you have lymphedema, you may have cardiac defects. So all the classic Turner risk will apply to them. So although you're not labeling them as Turner syndrome, the risk for hearing, the heart, and all those things are pretty similar as compared to the Turner in this situation. The other situation is a Y chimerism, in which you have a normal XX and the Y has fused in that. So these two cell lines have fused basically. It's a zygotic fusion, and this will behave like a 46XX, and you have a XY. Gonad here would be a bit different. You may have a normal or dysgenetic testis, normal or dysgenetic ovaries, and a streak gonad may also happen. Features will again be genital asymmetry. You will have Mullerian structure on one side maybe and testis on the other. So this is a very strange combination which may happen, and gonadectomy again becomes important. So there's a subtle difference between Y chimerism and a zero XY mosaicism in that perspective. There will be no features of Turner syndrome out here. The other complicated situation is, of course, over-testicular DSD. So when you say over-testicular DSD, you want to say that there is a ovarian tissue and the testicular tissue in the same individual. The defect here is again mosaicism, which is at the level of the gonad. So it's not a systemic mosaicism. Only in the gonad you have a differentiation, and you can either have an ovary, testis, or an ovotestis. When you basically say that this is an ovary, you have to document a granulosa cell out there, and you have to document a Sertoli cell for it being to be testis. So this needs to have a histological confirmation of both testis and ovary, and that's essential for this over-testicular DSD to be there. Management is difficult, and we'll discuss this in much more detail, and gonadectomy may be required at the end in that regard. So this is a bit about the overview of this complicated field of sex chromosome DSD. Now we have formed the basis with regards to the physiology, with regards to the etiology, the classification. Now we discuss about the assessment, and there are two important aspects in that regard. So when we have a disorder of sexual development, there are three major questions that you have to answer. Is it really DSD? What is the cause of DSD? And what's the diagnosis? So for that, you need to have a very, very meticulous approach, because there are so many diagnostic considerations, so many variability, and that's why we have divided into two parts, clinical and investigational. And for that, I like to invite Dr. Neha Agarwal, who was our fellow in pediatric endocrinology and who is currently working at the Himalayan Institute of Medical Sciences in Dehradun and working in the field of pediatric endocrinology. Neha, welcome, and over to you for the clinical assessment for DSD.
Very warm good evening to all, and many thanks to Dr. Anurag sir again for giving me this opportunity to speak on an important topic of DSD. So DSD is not only a medical emergency, but also a social emergency. So in this regard, the main aim of clinical assessment is to exclude the presence of life-threatening conditions like 21-hydroxylase deficiency, and also at the same point determine the etiology to decide upon the gender of rearing and subsequent management. So the first step in the clinical assessment of DSD is to ascertain or confirm whether it is actually DSD or a normal variant such as buried penis. After confirming the presence of DSD, the second step in the evaluation is to broadly classify the DSD into either of the three groups, that is XX, XY, or the sex chromosome DSD, which have already been covered in detail. And the third step is to identify the cause of DSD using proper meticulous investigation and workup. Coming back onto the fundamentals of social development, which happen under the influence of the genetics and determine the development of a unicellular cell either into a testis or ovary, depending on the underlying genetics. The gonads further form the testosterone, that is the male hormone, or the estrogen, that is the female hormone, which act on the respective receptors, that is the androgen and the estrogen receptor, to help in the development of external and internal genitalia. Finally, determining the gender identity. Any discrepancy in the external appearance and the genetic sex is what is known as disorder of sexual development. So what actually comprises DSD? Presence of atypical genitalia, cryptorchidism, penoscrotal hypospadias, these are all few examples of DSD. So broadly speaking, in a phenotypic male, presence of bilateral cryptorchidism, severe hypospadias, that is penoscrotal hypospadias, hypospadia with undescended testes, or hypospadias with micropenis constitute DSD. Similarly, in a phenotypic female, presence of inguinal or labial gonads, labial fusion determined by anogenital ratio that is above 0.5, clitoromegaly, that is presence of a phallic length of more than 0.9 centimeter, and presence of pubertal virilization or amenorrhea comprises DSD. Now, there are certain normal variants which may look like DSD but are actually not DSD and do not require any further evaluation, such as prominent clitoris, which may be seen in premature neonates, and these neonates do not actually require evaluation, labial adhesions, and penile hypospadias, which are normal variants and might be confused as DSD. On further evaluation, it is important to determine the phallic size accurately, which is done using a rigid transparent ruler on the dorsal aspect of the phallus extending from the pubic symphysis to tip of the phallus, excluding the foreskin. Any length less than 2.4 centimeter in a phenotypic male comprises micropenis, and more than 0.9 centimeter in female points towards clitoromegaly. Apart from the phallic length, it is important to determine the mid-shaft diameter and palpate for the erectile tissue. Moving further, it is important to determine the number of gonads and the location of gonads by feeling or by palpating using two hands, one placed on the superficial inguinal ring and the other on the scrotal sac. Any round, smooth mass palpable in the superficial inguinal ring is usually a testis. Sometimes or rarely there may be presence of prolapsed fallopian tube in the inguinal canal, and rarely we may find heterogeneous mass which is ovotestis. So moving further, it is important to determine the Mullerian structures. So during this presentation, we are mainly focusing on the clinical examination, which will help us broadly categorize the DSD patients into XX or XY DSD. So Mullerian structures can be identified using clinical examination or a per rectal examination using ultrasound or MRI imaging, and we may sometimes find a hemiuterus. The number and openings of urogenital opening and the extent of confluence, that is proximal or distal, is important in terms of surgical management from there onwards. And it is important to determine the extent of masculinization in a female using Prader staging, which extends from stage 1 to stage 5, in which stage 1 denotes a typical female phenotype and stage 5 denotes a male phenotype. Using just the presence and absence of gonads and Mullerian structures, we can broadly classify our patient into either XX or XY DSD, wherein presence of Mullerian structure in the absence of gonads denote XX DSD, presence of gonads in the absence of Mullerian structure denote XY DSD, whereas presence of both the gonads and Mullerian structure is indicative of anti-Mullerian hormone or ovotestis, and absence of both the gonads and Mullerian structure is found in conditions such as anorchia or XY DSD sometimes. Karyotype is an important investigation which helps us confirm the genetic sex of the individual. Given the high chances of mosaicism found in these individuals, it is important to send a 50 metaphase plates at least. And there might be some conditions in which we need to determine the sex early. And since karyotype takes around a turnaround time of 21 days, a FISH technique can be used to determine the Y material or the SRY gene. Then there are certain clinical pointers which may help us to identify the etiology, such as presence of pigmentation, points towards congenital adrenal hyperplasia. Hypertension gives us a clue about 11-hydroxylase or 17-hydroxylase deficiency. Then there is a list of steroidogenesis defects which are associated with salt wasting condition. Skeletal dysplasia may be seen in conditions associated with SOX9 mutation or POR deficiency. SLO syndrome is associated with polysyndactyly, and as Sir has already highlighted, a presence of abdominal mass in XY-DST should exclude 2WT1 defect, and maternal virilization is seen in conditions such as aromatase, POR deficiency, luteoma, or ovarian tumor. So with this, I would like to again reinforce on the importance of determination of gonads, presence or absence of gonads, and Mullerian structures to broadly classify into XXDST or XYDST, and from there on, narrow down the possibility of the cause and investigate accordingly. With this, I would like to close my talk and hand over to Dr. Anurag. Thank you, sir.
Thank you, Neha, for the wonderful discussion and really making my job very easy. So by the clinical assessment, as Neha has said, that if you just are very careful in terms of clinical evaluation, you can really don't need a karyotype to begin with. Your working diagnosis is made. So as this slide is the most important thing to remember, and this is very well emphasized by Neha as well, that you just have to look at two things: Mullerian structures and gonads. So if you have got only Mullerian structures, no gonads, it's XXDSD. If you have got gonads with no Mendelian structure, it's XYDSD. If you have got both of them, you're talking about a AMH problem or over testicular DSD. If you have got no testes and no Mendelian structure, that's anorchia or XYDSD. Now, a few tips to remember: when you feel a gonad in a child with atypical genitalia, it usually is testis. Now, testis usually is a round structure. It has got similar consistency. If you find areas which have got different consistencies, it may actually mean that this may be a over testis in that perspective. Similarly, sometimes fallopian tube may actually prolapse, and that may give like a gonadal appearance. So you have to be a bit cautious. For Mendelian structures, you can do three things. You can look at upper rectal examination, look at ultrasound, or look at AMH. So if your AMH is undetectable, it basically means that there would be a Mendelian structure which will theoretically be present from there. Now, in that perspective, if we then move forward with regards to the further evaluation, go in terms of the workup now, and we'll talk about the various investigations, when to do, what to do. It becomes very confusing because always, whenever I give a talk on this, there's always a question: what is the best time, which test to do, how to interpret, stimulation, no stimulation. So we've done a very, very systematic and simplified approach out here. So in a way, the workup will include the basic hormone tests, particularly electrolytes and 17-OHP, especially if you have a non-palpable gonad. Non-palpable gonad with atypical genitalia is equal to CAH unless proved otherwise. So this becomes important. If you have got a palpable gonad, then this LH, testo, and AMH become important. So while I'm talking about all these investigations, we need to prioritize in that setting. Similarly, investigations like DHEAS, androstenedione, DHT, and inhibin A, I would say we should keep at a second line. So we are trying to simplify workup with easily available investigations and not complicated it too much. Imaging has a role, of course. Ultrasound, as I said, will tell you about the Mendelian structure being present or not, and we can look at the karyotype, which will give you the genetic diagnosis. If it's not available, it takes too long a time, you can look at FISH for Y chromosome, or you can also now look at the targeted sequencing or the next generation sequencing in that perspective. Now, the most important investigation in somebody who has got a non-palpable gonad is 17-hydroxyprogesterone, because you want to exclude 21-hydroxylase deficiency right at the onset. The precaution, however, is that do not rush. Crisis because of 21-hydroxylase will not happen before 3 weeks of life. So you wait till around 72 hours, do an extracted sample, because there are a lot of these metabolites which are circulating in this age group. And interpretation, if the level is really high, above 100, that will suggest the possibility of it being 21-hydroxylase deficiency. 10 to 100, it's 3-beta or 11-hydroxylase, because they can have mild elevations in terms of 17-OHP. And in between, you can do a ACTS stimulation test as well. If you talk about the assessment for somebody who has got a palpable gonads, you have to basically look at the various factors. What you need to remember is that testosterone levels may be unreliable beyond the mini puberty. So the best test for the Sertoli cell function is actually AMH. Inhibin B has a role later on. So if somebody comes to you around 9 to 12 years, which is unlikely for DSD, you can do inhibin B, but otherwise AMH is good enough. If somebody is beyond mini puberty, so pretty much beyond 6 to 12 months of life, you can think of doing a HCG stimulation test, giving HCG and seeing that. So if the inhibin is about 35, post HCG testosterone is more than 200, and AMH is detectable, it means that there is a functional testicular tissue. Now, why would you do a LH? LH is the best marker for somebody who has entered mini puberty or not, and it gives you information about the possibility of overall whether you need to do a HCG test or not. So it provides information about mini puberty and gonadal failure. It should be done after 7 days of life, because there is a fall in LH, immediate surge, and then it should be done after 7 days. The interpretation, basically, if the LH is more than 0.7, suggests that somebody has entered mini puberty. If it's very, very high, it may indicate gonadal failure. And of course, if the levels are very, very low, you can do a GnRH test or a HCG test in that regards. Testosterone levels are important mainly to look at the gonadal function and to distinguish between the deficiency versus resistance. They should be done again after 7 days of life using a GCMS. So if you have somebody in the first day, you can do a LH in testosterone, but usually patients will come later. So after that, you should wait for at least 7 days to identify. GCMS is important because again, a lot of these other metabolites which are there. Interpretation, if it's low, it's a steroidogenic defect. If it's high, it's 5-alpha reductase deficiency or AIS in that situation. DHEAS is a marker of adrenal androgen production. I would say it's not very, very important right at the beginning. But if you have somebody who has got gonads which are palpable, testosterone which is low, then you start thinking of DHEAS, because this will tell you which is the site of that particular defect. It should again be done in an extracted sample with GCMS preferably. And if it's low, in somebody who has a XYDSD with a low testosterone. So XYDSD, low testosterone with low DHEAS suggests a very proximal defect, star and side chain cleavage. High, it's 3-beta HSD in that setting. If you move forward from that block, you talked about DHEAS, now we talk about androstenedione. The role basically is for 17-beta HSD. It will be very high there. Again, after 7 days, and if it is not, LH is not more than 0.7, do HCG stimulation. Testosterone to androstenedione ratio, if it's less than 0.8, indicates a 17-beta HSD effect. Dihydrotestosterone, you're moving down that same cycle which Chetan had discussed a lot. So this is a marker basically for the 5-alpha reductase deficiency. Again, after 7 days, if the testo-DHT ratio is more than 10, it means you're dealing with 5-alpha reductase deficiency, while if it's less than 10, it is AIS. However, there are a number of studies which have shown that these are biochemical tests and they may not be foolproof. You may have an overlap. So if there is a real doubt, getting a genetic diagnosis may be more useful in that perspective. AMH is very important. The role again is mainly for Sertoli cell function. If you are not very sure about the Mullin structure, you can look at the AMH level, and this will be helpful. Any time of the day you can do it. It's a peptide hormone, so it is not affected by steroids, no need of extraction. If the levels are more than 30, they go in favor of a functional testicular tissue, while in a XX it's less than 10. So it's a big dichotomy. So it's a good test to really look at whether the Sertoli cells are there and they are functioning or not in that situation. And if you have very high AMH, of course, that's a resistance, very, very rare situation in that setting. Inhibin A, again, a very rare test. I would not do that very often, but this may be a marker of ovarian function. It will give you, particularly if you have a borderline case like XY, XXY, the question is, do you have a ovarian tissue? We talk about that. If you talk about X0/XY, we always talk about, is there a testicular tissue, and do a HCG test or a AMH? It's the opposite way. So if you have got a male appearance and in that you've got a double X basically, which is there in the form of a mosaicism, the question is whether the ovaries are there or not, because if the ovaries are there, you have to take it out. In that case, you can do a baseline and a HMG stimulated inhibin A, and if inhibin A is detectable, this is ovarian tissue. So these are two distinct situations. You're talking about testicular tissue in an XX individual, very important because it will cause virilization, and gonadectomy may be required if the situation is like that, and ovarian tissue in a XY individual, because then you have to remove it out. HCG stimulation test is predominantly required if you are not in the mini puberty. So most patients will come around when your LH is more than 0.7, you don't need that, but if the LH is less than 0.7, you can do a HCG stimulation test. Now you do a baseline androstenedione, testosterone and DHT, give HCG, and then after 72 hours you do the report and you will get the interpretation based upon that. ACTH stimulation test basically is for borderline 17 OHP when you are basically in doubt whether you are dealing with a possibility of a different steroidogenic defect. So in that case, you do adrenal function assessment. So you give 17 OHP, pregnenolone and DHEAS. You give ACTH and see how it increases after 60 minutes. It will give you the which form of steroidogenic defect you're looking at in that situation. Now, if we now go into the specific situation, if you have got a very high DHEAS in the setting of XX-DSD, you should start thinking of 3-beta-HSD, and in that setting, the test to do would be 17-hydroxypregnenolone. If you have XX-DSD with salt wasting, you're thinking of mostly 21-hydroxylase, 17-OHP levels more than 100 would be characteristic. If you have salt wasting with mild elevation, think of POR, 3-beta-HSD can also cause a mild elevation. If there is hypertension, hypokalemia, alkalosis, along with XX-DSD, you think of 11-hydroxylase and do 11-DOC in that situation. So if you now summarize is that if your 17-OHP is more than 100, don't bother about anything else. This is 21. If your 17-OHP is high, DHEAS is also high and DOC is normal. So we're talking about 10 to 100 nanogram per ml 17-OHP. This is 3-beta-HSD. If you have got 10 to 100 17-OHP, high DHEAS, but very, very high deoxycorticosterone, you're dealing with 11-DOC in that setting. And you can also have a variation of POR, which may happen in that situation. Now, if you go to the other way around, so this was the androgen excess in the setting of XX-DSD. If you go on to the XY-DSD, where you have a problem of any of the steroidogenic pathway, most important, the first one would be Smith-Lemeli-Optis syndrome, which you will consider with mild salt wasting, mild DSD. Sometimes it may cause reversal, but usually there's mild. Your aldosterone levels will be low and your lipid levels will be very low. If you talk about side chain cleavage or star, all metabolites will be low. For 3-beta-HSD, DHEAS will be high, 17-hydroxypregnenolone will be high. For 17-hydroxylase, you will have hypertension and you will have a high level of 17-DOC. For 17-beta-HSD, you look basically at the DHEAS and androstenedione levels. For 5-alpha reductase, you look at testo to DHT ratio, and then this will also differentiate between 5-alpha from partial AI. So whatever test we're discussing about will really help you classify the different forms of DSD in that perspective. So if you have DHEAS, andro, testo, DHT, you will know the diagnosis. So first case, you've got low DHEAS, low andro, low testo, low DHT. Diagnosis, Pratik? So if all are low, you're talking about a very proximal defect. High DHEAS, all the other low. So that will be a POR, 3-beta, or really 17-hydroxylase also will be there. You've got high DHEAS, high androstenedione, low testo. That is 17-beta-HSD. You have got high DHEAS, high andro, high testo, low DHT. 5-alpha reductase. All high, 5 androgen insensitivity. So if you just remember these 4 into 5 table, which looks like a bit complicated, but very simple if you think about it from your steroidogenic pathway. If all low, proximal, all high, resistance. If you have a predominant increase in DHEAS, you're dealing with 3-beta. If you have an andro excess, it is 17-beta. Testo excess is 5-alpha. So it's not a very rocket science sort of a thing. It's a very simple thing to understand if you now remember this table. So there are 2-3 slides which are there in this presentation. If you remember, the one was that gonad and how they appear and disappear, tell you about XX-XY-DSD. One is this one, and one for XX-DSD. You will know exactly where you are heading in terms of evaluation and management. Now, genetic testing is important, very importantly for XX testicular DSD, which is very, very important. If you have got a XX male, so to speak, the first thing you will do is SRY, because 90% of them will have SRY. Then you will do NR5A1. If you have a XY DSD, that's a very complicated situation. Now, I've talked about that table, which looks simple, but often there could be confusion. So in XY DSD, we are now moving from a biochemical diagnosis to a genetic diagnosis. So if you're thinking of a gonadal problem, of course, do a NR5A1. If you're thinking of AIS, do an androgen receptor study, and then WT1 SRY would be important from that perspective. If there is gonadal dysgenesis, you have to think of WT1 very importantly, because that could result in renal failure. And RFI1 and SRY will also become important from the clinical perspective. Now there are different panels available, especially with the exome sequencing, which gives you the diagnosis, and that will be important from that perspective. Once you diagnose DSD, also look at associations. So for XY DSD, do an abdominal imaging to look for a renal mass. Look for proteinuria. For XY, think of Turner syndrome association. So this will behave like Turner syndrome. Look at cardiac, hearing, and all the other problems which are there. They also are at increased risk for aortic dissection. So all the criteria for echo and everything are the same, which will happen for Turner syndrome. Y cell line, always think of gonadal malignancy, and that becomes important. So now if we just focus on individual evaluation, if you have atypical genitalia in the form of bilateral cryptorchidism, inguinal gonad, scrotal hypospadias, micropenis and hypospadias, look at the first thing. Are the gonads palpable or not? And are the Mullerian structures there or not? If you have got no palpable gonad with a Mullerian structure, your job is very, very easy. So this is a XDSD, most likely CH, do a 17 OHP. If it's high, it is 21. If it's normal, do DOC, it will be 11. So this will give you diagnosis. If, however, these levels are normal, ask for maternal virilization, which will give you a clue towards aromatase or POR, and all that is normal, then you think of a gonadal dysgenesis. So this arm is easy. No gonads, Mullerian structure present. Very simple. No MH being formed, and this is a XXDSD. Now, if you have a palpable gonad and you have a Mullerian structure, this is also easy. Basically, what it means is that gonads are there, but they are not working. They are not producing AMH, or the AMH is not working. So you do a AMH. If it's low, it is dysgenesis. If it's high, it is AMH resistance. The confusion becomes important if you have got present or absent gonads and your Mullerian structures are absent. What does it mean? It basically means that there was a time when AMH was produced. Now there is no AMH. So it basically tells you that this is most likely a XY DSD, and the evaluation there will start with androgens. Do a DHT level. So you do a testosterone levels first. If testosterone is high, which means it's not acting, you do a DHT. If it's low, it is 5 alpha. If it's high, it is AIS. So that ratio of testo DHT of more than 10. If testosterone is low, it means there is a steroidogenic defect. This could be a combined with adrenal or a local defect in terms of testis. So you look at salt wasting. If there is salt wasting, all that star, side chain cleavage, POR3 beta will come into the picture. If there is hypertension, it is 17 hydroxylase, and if it is normal, it is LHCG receptor and 17 beta HSD. So this whole flowchart may look a bit complicated, but it's actually very simple. You're talking about a 2x2 table of palpable gonads plus minus, Mullerian structures plus minus, and then if it's XY DSD, you have to dig deep about testosterone levels, DHT levels, and salt wasting, give you a diagnosis. If you're talking about XX DSD, you exclude CH, and then aromatase, and this is a rare situation of AMH resistance or dysgenesis. You will find that. To simplify all that, we have put forward in our mobile application, the MediClasses endocrinology app. You just have to answer questions yes, no, and the same algorithm will work quite effectively to identify the case in that. So now what we'll do is that we'll move forward to the cases, and we have got Dr. Prateek who will present the case, and I'll discuss those cases simultaneously in that regard.
Thank you, sir. So we have the first case. A 1-month-old child with DSD was Prader 4 at birth. Now this child had palpable gonads and the karyotype showed 46XY. So then, thinking this that it is an undervirilized or there is low virilization, it was given testosterone 25 mg in 3 doses, which further.
So do you agree with the diagnosis of XY DSD, Prateek? Yes.
So,
there is Prader 4 palpable gonads are there and there is no Mullerian structure. So this
yes,
is
I will agree
clearly
with
XYDSD.
46X. Yes.
Now testosterone is given. Do you agree with this testosterone or not?
First, we need to find out what the problem is. Then only we need to move forward. Actually,
so testosterone may be given, but you have to look at the cause as well. And so this is the XYDSD, and this we discussed in the first case that landed 5 years later with renal failure. So again, this is a very, very important situation. You have to be very bothered about of a WT1 defect, which may have an effect in that situation. So this is a big message that you get out of here, is that you should always do genetic studies, confirm the diagnosis. It's just not just X6, X5. There's nothing called XYDSD. You have to reach a particular diagnosis in that setting.
Coming to the next case, this is a 3-day-old girl who preterm at 29 weeks was noted to have clitoromegaly. Now, there was no labioscrotal fusion or any other signs of any DSD. There were no palpable gonads. And now, investigation at the 29 week was seen that LH was high and FSH was high.
So how do you interpret this LH and FSH, Pratik?
So as we know, at preterm, there is that the LH and FSH are in the process of falling and it has not completely fallen. So they might get a falsely high positivity LH and FSH levels.
So what is the significance of isolated clitoromegaly that you're seeing here? There is no labioscrotal fusion. There is just clitoromegaly. Do you think, what is the physiological relevance of that?
Yes, so basically, in preterm girls, we might falsely claim that as clitoromegaly, but it is because of the labial edema that the clitoris seems enlarged and it settles down within a few days.
So very important message is that if you have got no labioscrotal fusion, it means that if at all there was an androgen exposure, it is after 12 weeks. So why would somebody get androgen exposure unless the mother is taking some medication or there is a tumor in the mother, which will be evident. So without labioscrotal fusion, if you just have isolated clitoromegaly, I would have a huge doubt whether we are really dealing with a situation of DSD or not. So this, as you have mentioned very clearly, Pratik, that this is a clitoromegaly of prematurity, which is very commonly seen, which is of not much consequence in that regard.
Now we have a 3-day-old child with DSD. Now it was seen that it was Prader4 and gonads were not palpable. So when we have gonads, the next step obviously comes to see Mullerian structures are present or not. Now it was seen that there is a Mullerian structure present, which essentially makes it a 46XX DSD. Now further evaluation showed that the 17 OHP was 25, raised but not very raised, and it was termed as a CAH.
What would you have done if the child had come to you with a 17 OHP of 25 with an X6 DSD?
So I would like to evaluate further actually, and 25 is not very high. Genetic testing would be helpful in this situation, and take further history also.
Or maybe ACTH
or
test
ACTH
will also help you out on that. So this girl was managed as CAH.
So with this CAH, hydrocortisone started, but then gradually tapered, and eventually it was seen that this child has a normal 17 OHP. So then after this child was sent home, this child presented with delayed puberty later. And now we come to the question, is it really CAH and are we missing out on something? Yes, sir. So we have a delayed puberty, and what further we found out that there was history of maternal virilization, which ultimately leads us to the diagnosis of an aromatase deficiency and not a CA or not a classical CAH.
So I think this is a very, very important message again in terms of diagnostics, because often there could be confusion at that time, but then you start treatment, but be wary. So this physician was very proactive. They found the 17 OHP was low, they tapered it out, and then still the 17 OHP was normal, and then they referred us with delayed puberty. So what it means, there was androgen excess, then now there is estrogen deficiency. This is clearly aromatase deficiency. So if you really look into our application, you will find that last simple question, atypical genitalia, yes. Palpable gonads, no. Mullerian structure, yes. So X6 TSC, 17 OHP less than 100. That's important. DOC should have been done, and maternal virilization, so it's aromatase. So if you use these algorithms, it will really help you out in terms of diagnosis.
So coming to the next case, this was a 15-year-old girl who presented with delayed puberty, and it was found that she had an inguinal gonad. So
now the question really starts. If you have an inguinal gonad, is it really delayed puberty now, or is it something else?
So now if we have it goes towards more of a DSD, more than delayed puberty. Now it was actually found that there were no Mullerian structures present. So the next step comes to see whether, now this is obviously we have no Mullerian structure pointing towards an XY DSD. So next step is to see androgen levels. Now before the androgen levels, it was seen that the FSH was very high, and of course 46XY as were expected. Now testosterone levels came low. So the next step obviously comes to see the sodium status. Now, in this individual, we saw that there was hypertension, which pointed us more towards a CH of a 17-hydroxylase deficiency associated with hypokalemia.
So I think this again is a very interesting thing. If you have a palpable inguinal gonad, if you have got a bilateral cryptorchidism in apparent looking like a male, always think of 21 hydroxylase. If you have inguinal gonad, think of a DSD in a girl as well. And as Pratik has very nicely pointed out, hypertension would really give you a clue towards 17 hydroxylase. And if you go by our algorithm, there is a atypical genitalia, palpable gonads are there. The next step would of course be to look at the mineral structures which were not there, look at testosterone, and we've got the ranges which are there. Testosterone is low, blood pressure is high, so it's 17 hydroxylase. So although this algorithm can help you, otherwise you can simply use this tool to help you out.
Now we have a 6-week-old girl who presented failure to thrive. She had actually just gained 100 grams. It was noted that a girl with bilateral palpable gonads, now we go towards the DSD, no Mullerian structures. So essentially this is an XY DSD. Again, we look at the androgen levels. Now here the androgen levels, now the sodium status showed that it was a hyponatremia with a hyperkalemia, suggestive of some sort of salt wasting.
So XY DSD with salt wasting.
Yeah.
Very narrow diagnosis, which all possibilities.
So one of the proximal features such as STAR, SCC, SF1, SLO, Smith-Lemli opids, etc. we can
something
say.
very, very early, which is affecting both the adrenals as well as the testes.
So in this individual, there was syndactyly and microcephaly, upturned nares, suggestive of Smith-Lemli opid syndrome.
So again, a very, very interesting situation where you have got a apparent female who has got gonads. So this was the opposite of the first situation which we discussed, which was CAH with bilateral cryptorchidism, similar to the second case of 17 hydroxylase where you had bilateral gonads along with a female appearance. This child actually has got bilateral gonads, syndactyly, upward nares, just to a lipid profile, you will get SLO as a diagnosis.
A 4-week-old girl with atypical genitalia, it was seen that inguinal gonad is now present, makes it a DSDS. No Mullerian structures. So of course, XY karyotype as expected. Now we looked at the androgen levels, which were low. And now there was normal growth and development, no issues, no salt wasting, and no hypertension, which brings narrows it down to only 2 diagnoses, the LHCGR or the 17 beta. It was seen that the LH levels were high, which was suggestive of LHCGR defect.
So this is again a rare situation, but important to understand. So basically, if you have atypical genitalia with palpable gonad, no Mullerian structures, with low testosterone and no salt wasting, that would be one thing that you have to really think about this possibility. And androstenedione will help you reach a diagnosis in that setting.
A 11-year-old boy with early puberty, height 134 and weight 34 kgs. Now pubic hair is present. So pubic hair is 4 stages present. However, no gonads are present.
So what does it mean? This becomes a...
So DSD is there. We need to look forward now. So now when we saw it, the Mullerian structures were actually present, making it essentially an XX DSD. Now we need to look forward, and the karyotype was X as I expected. Now there was hypertension in this patient, which makes it more towards the CAH, and as expected, we expect high DOC levels. So probably this was 11 beta hydroxylase deficiency.
Again, a very interesting case, opposite of the 2 cases we discussed earlier. There was a atypical genitalia, the palpable gonads were not there. So a male with no palpable gonads, Mullerian structure present, which means it's an XX DSD, 17 OHP not high, DOC high. So this is towards a 11 hydroxylase essentially in that regard.
Now 15-year-old girl with primary amenorrhea, height is okay, weight is 48 kgs. Breast staging has reached 4, pubic hair has reached 2. Now inguinal gonads are found on examination. Uterus absent, karyotype was XY. So now we have a karyotype XY. Now we need to look at the hormonal status. Testosterone was very high at 600 Ng per DL. Now we are limited to only 2 diagnoses. The TDHT ratio came low, now suggestive of a complete AIS.
So this is how we go forward. So you've got somebody again mainly presenting with atypical genitalia. You've got palpable gonads, no Mullerian structures. Testosterone is not low. So this is the opposite picture. It's high. Then the testo-DST ratio giving you a picture of a AIS in that regard.
Now 10-year-old girl with clitoral enlargement. And it was seen that she has a phallic length of 2.2 centimeters. Now bilateral gonads were present, and it was seen that the uterus absence is over XY DSD. Now again, the androgen status, testosterone was 150 Ng per DL. Now, further, the T-DHT ratio was more than 10, which narrows it completely towards the 5-alpha reductase deficiency.
And this is a classical presentation
At
of 10
10
is at 9. So this girl was reared as a girl, has now got a development which is happening. And this again is an atypical genitalia with a palpable gonad, with no million structures, with high testosterone and a high testosterone ratio. This is 5-alpha reductase deficiency.
A 17-year-old girl presented with primary amenorrhea with no breast development or pubic hair development. Now the karyotype was 46XY.
You think this is DSD?
Yes, it is rarer as a girl, no breast development. We need to look further.
So there's a discrepancy between the chromosome and that. This is not an atypical genitalia in your classical cell, but there's a primary amenorrhea. That's why a karyotype was done. So what do you think can cause XYDSD causing primary amenorrhea with a normal female appearance?
So normal female appearance XYDSD I would consider CAIS, androgen sensitivity syndrome.
Yeah.
So in this there were no gonads were present.
What else?
So so uterus was present in this, and it was XY. So there's a uterus is present, and well as the XYDSD is present. So this is a discrepancy.
Yeah.
So probably at some point AMH has not been released from the XY, so probably suggestive of a dysgenesis of the gonads, and SRY was positive, so suggestive of a gonadal dysgenesis.
So this was a confusing picture which can happen with gonadal dysgenesis. So I think this was a very interesting discussion, and which basically looked into the different aspects, starting right from X6, XY, and all the aspects which we discussed in terms of evaluation. So now we've discussed about the pathophysiology, the classification, the assessment, but at the end, this is the most important part. How do you manage? Otherwise, what happens? We all talk about DSD being a medical emergency, a social emergency. I would say DSD is also an emergency for the doctors, because often they rush forward looking for how to treat, how to evaluate, how to manage. And that's why we're trying to demystify that in that perspective. So the key questions which a child with DSD is asking you is, how do you stabilize the child? What would be the gender of rearing? Is there a role of gonadectomy or not? And what are the long-term management which happens? So initially you have to stabilize the child, look for pointers of CH. If there is a non-palpable gonad, that is an emergency. If there is a XY with low testo and no uterus, again think of some rarer male variant CH, what we speak. Evaluation, do a 17 OHP, electrolytes, and manage with steroid replacement and fluid boluses as required. Counseling, very important, has to be comprehensive, talk about pathophysiology, long-term issues, fertility, sexuality, contextual assessment. So every culture will have a different expectation. Don't try to break those barriers very quickly, and don't be over paternalistic in that regards. It should be open-ending and non-prescriptive in that regards. So now we'll discuss about two major issues of management. One, of course, about gender of rearing, which Dr. Sajili will talk about, and then we'll discuss probably at the end of it about the gonadectomy, which Dr. Prateek will talk about. So I think I'll hand over to Dr. Sajili, who will talk about a very, very important issue, a very controversial issue about gender of rearing. And what she's going to do is that she'll guide us. She's not going to say that you should follow this gender of rearing, because it's not a perfect thing. It's not like a mathematics. Everything we've discussed here is like mathematics, science. This is more of art of DSD. So she's going to help us about which way would be the best way forward in that regards. Dr. Sajili is currently working as a consultant at Pune. And welcome, Dr. Sajili, and please go ahead.
Thank you, sir, for a good introduction. Good afternoon, everyone. Today we'll be discussing about the gender.
Your volume is a bit less. Can you come forward a bit?
Yes, sir. Is it audible now?
It's better now.
Yes, sir. Good afternoon, everyone. I'm Dr. Sajili Mehta, and today we'll be discussing about the management of DSD. As sir has described, that management of DSD is a holistic approach which requires involvement managing the emergency conditions, to gender assignment, to associated complication management, and a long-term follow-up and outcome. So now I'll be talking about gender assignment. This is a most very important and a challenging decision to do in a patients with DSD. So if we look at the history of DSD and the evolution of the technology treatment or the healthcare provided to the patients with DSD, we can see that gender assignment has changed over a fundamental time, over this time, fundamentally. Initially, the assignment of gender was based on the gonadal tissue that was present. Later, then it was switched over to the karyotype, and on the basis of karyotype, gender assignment was done. Later, with more understanding, they switched over to the ability to create a surgically functional gonad or genitals. After this, this was till 2006 when the consensus guideline came for the
Sajali,
iDSD. Yes, sir.
can you just keep it a bit closer, the mic? The volume is a bit less here.
Okay, sir. Is it now okay, sir?
Much better, much better.
Yes, sir. So after 2006, when the consensus guideline for DSD evolved, there have been lot many changes and better understanding of patients with with DSDs. So now the gender assignment is not only based on the gonads or the sexual appearance. It depends and it involves multiple factors. The multiple factors that play a role in gender assignment are gender identity. Gender identity is basically uh, how the person identifies himself, whether as a male or a girl, and it is important factor that has to be considered when assigning a gender. But it is not at birth, it is very difficult to predict the gender identity of the person, but various other factors can help in supporting the gender identity, which we will be talking in the next slide. The other important factors that need to be considered are the social or societal norms, the fertility outcomes, and the sexual orientation of the person. In addition to that, one also needs to understand that antenatal androgen exposure has effect on the brain programming, as well as it can cause virilization of the child. And depending on the virilization and the programming of the brain, one may need to assign gender properly. Various social and cultural norms or cultural issues may be of the particular region also play important role in gender assignment. And if not, finally, surgical outcome is also important, because some surgeries may be possible and some may not be possible. So considering all these factors, what is the best gender that can be assigned to the child is important. This is very important, so as when we assign a gender to a child, he is being reared as that gender, and it should not later create some gender dysphoria in this child when he goes into puberty. So just let's talk about gender identity in brief. As we all know, gender identity, as described, is like whether the person identifies himself as a male or a female. So gender identity depends on various factors, or various factors have an influence on the gender of the patient. One of the most important is the karyotypes. Presence of Y chromosome does have an influence on gender identity of the person. Our brain structure is a dimorphic structure, and depending on the various hormonal exposures and genetic exposures, it can develop into different types and have different identities. The other important factor that can contribute to gender identity is the fetal environment. Androgen exposure in the antenatal period can also affect our brain programming and can cause different gender identity as well. And last but not the least is the postnatal outcome, how the child is reared, what are the cultural norms that are followed. All these things define the gender identity of the child. So, after discussing what is gender identity, now we will discuss individual cases in detail and how should we help the child or help the parents in assigning the gender. This is not like if it's a 100% rule, but it will help us guide in the management of treatment. So first, coming to the most common form of DSD, that is a XX-DSD, a 21 hydroxylase deficiency. In this cases, we all know that there is a defect in 21 hydroxylase, which prevents formation of cortisol and aldosterone and results in excess of androgens. So why we know that the child has been exposed to androgens in the intrauterine life, which causes virilization. And depending on the virilization, we can grade them according to the Prader staging. In this child, most of the times, considering the fertility aspects and the sexual aspects, gender of rearing may be considered as female. rarely these patients do have gender identity issues. So, and mostly, I'm not saying 100%, but mostly in the XX DSD patients at birth, the gender of rearing may be used as a female, but after proper discussion with the parents. And one should not be in a hurry to do surgery. Surgery is recommended only in those children who have Prader stage 3 and more of virilization. And the surgery involves vaginal mobilization so as to have a functionality. So let's talk about the surgery. As we discussed previously, the indication for surgery is only when the child has virilization of Prader stage 3 to stage 5. The timing of the surgery depends if the gender of assignment gender has been decided. If it is clear in the early stages that the child is going to be reared as female and the diagnosis is confirmed, in that cases surgery can be done early as it can help prevent recurrent vaginal sinus infections due to a common pathway between the uterus and the urinary bladder. The procedure that is done in these patients is vaginal mobilization. Clitoral reduction surgery should not be done or should be avoided as it can damage the neuromuscular tissues. And one should, when after doing this surgery also, one should keep assessing these children, and they should have been controlled properly with medication so that they do not develop any gonadal adrenal rest, which can again produce androgens and cause further virilization in this child. So one needs to be very meticulous in monitoring these patients and having a proper compliance with treatment. In some situations or very rare situations, when the child with 21 hydroxylase deficiency presents at a later age, like during puberty with cyclical hematuria, who has been reared as male, or when they have severe virilization, or when there are cultural issues where parents prefer to raise a child as a male, in that cases we can consider as a gender of rearing as male. In these patients, when we consider them to be reared as male, a gonadectomy and hysterectomy can be planned accordingly. Moving ahead to the XY steroidogenic defects. All the defects below above the LHCG receptor will not have any effect of androgens over the brain. So, in the antenatal period, in the defects like side chain cleavage or dihydrocholesterol defects or 3 beta HSD, the gender identity will depend on antenatal androgen exposure. In this patient, since there will be no antenatal androgen exposure, the gender of rearing can be mostly as a female. And also, one needs to consider that since these patients do not have androgens, their gonads or the testes will be high up in the abdomen, and this will predispose them to high risk of malignancy. And hence, gonadectomy is advised in these patients. Considering all these factors, they may be reared as females. The defects below LHCG receptor, like the 17 beta hydroxysteroid effect, in which androstenedione is converted to testosterone. In this, the gender assignment depends on the androgen exposure in the intrauterine life and the amount of virilization. Since androstenedione can be converted peripherally in testosterone, so some androgen exposure will be present in these children, and hence it will be a guiding factor. In these patients, if the gender of rearing is considered as male, one can give a trial of testosterone injections, and a corrective surgeries may be done at 6 months to 18 months for repair of penoscrotal hypospadiasis, if any. If the gender of rearing is unclear, one should defer the surgeries, and till that time, one can use GnRH analogs till one is clear about the gender of rearing. The gonadal risk in 17 beta HSD defects is intermediate since the gonads are at the deep inguinal ring. And in these cases, if patient is considered to be reared as male, in that cases one can do a archaidopexy with proper monitoring of these patients for the risk of malignancy. Coming to the next defect, that is a 5 alpha reductase 2 defect. In this, we know that the defect is in conversion of testosterone to dihydrotestosterone. So, testosterone is present in the antenatal life as well, and hence they are exposed to androgens in the antenatal period, and there is some amount of virilization as well. So in these patients, most of the times the gender of rearing is male, and a testosterone injection can be given in the infancy with corrective surgeries done at 6 to 18 months of age when the gender of assignment is when the gender is considered as male. If unclear, depending on the virilization, if the child is very under virilized, one may defer the surgery. Until that time, one can use GnRH analogs. The risk of malignancy in this patients is in very less, around 3 to 5%. So one can do orchidopexy in these patients, and for frequent monitoring for gonadal malignancy is important. Now, going to complete androgen insensitivity syndromes. In this, since there is complete androgen insensitivity, there is no antenatal exposure to androgens, and hence the gender identity most commonly in these patients is female. Since the gonads are present at the deep inguinal ring in these patients, the risk of malignancy in the prepubertal child is very less, but the risk after puberty increases to around 10%, and hence it is recommended that one should defer gonadectomy till puberty or till complete sexual development has been achieved. And one should keep monitoring the gonads, and if needed, a repeat biopsy should be done to see for the intratubular changes or intraluminal changes. In patients with partial androgen insensitivity syndrome, the gender identity is variable. Many cases of gender dysphoria have been observed in these patients as there is variable exposure to androgens in the intrauterine life. One can also see that how they respond to testosterone. If there is a good response present, one may think of if gender of rearing of male, and one may delay surgery till it is clear. The risk of malignancy is also very high in these patients. If the gonads are abdominal, the risk is around 50%. And if it is scrotal, the risk is less than 30%, but is on the higher side. In these cases, orchidopexy should be done in infancy, and monitoring is very important, and where repeated ultrasounds and biopsy, if needed, should be done in the post-pubertal age. Now, going to the next important topic is XY gonadal dysgenesis. As we have discussed, the various genes involved in development of gonads can be affected and can cause XY gonadal dysgenesis. So, in these cases, the gender identity depends on the virilization or androgen exposure if it is there. Most of the times, these patients identify themselves as male and respond with testosterone and can be treated with testosterone. If there is any hypospadias, one can repair it around 6 to 15 months of age. In females, if the patient identifies himself herself as female, the surgical prospect is difficult because creating a vaginal opening will be difficult in these patients. The risk of gonadal malignancies is very high in this child, about 30%, if the defects are in NR5A1 and WT1. And there is abdominal gonads, and gonadectomy is indicated in these children at the earliest. In children who have XY DSDs or mixed gonadal dysgenesis, the gender identity also again depends on the androgen exposure, which is the predominant component, whether X or XY, and how much is the androgen exposure and virilization. Most of them identify themselves as male, and depending on the sex of rearing, we may have to look and decide about the further management. The gonadal malignancy risk is about 30% in these patients, and even those who have scrotal testes should undergo frequent biopsy to assess the risk of gonadal malignancies. As they have XXY chimerism, these gonads may become streak and have to be removed by around 10 years of age, as the risk significantly increases after 10 years. In patients with over-testicular DSDs, gender identity is variable and it can be flexible, and one should delay surgery in these cases till we will be able to talk with the child, understand his prospect. And the risk of gonadal malignancies is around 2 to 5%. If the child is considered to be is reared as male, one can remove the ovarian component of the over testicular tissue, and the testicular tissue that is remaining needs to be monitored frequently for any gonadal malignancy risk. If the child is to be reared as female, one may remove the ovotestes and supplement her with the hormones when needed at puberty. Thank you.
Sajali, for this interesting and very important discussion, because there is always a big issue which happens with regards to what is the most important aspect with regards to the gender of rearing, and this is often causing a lot of confusion in that regard. And you've really done a very good job in terms of telling us how to go forward. The main issue, of course, is that there are areas which are not very clear, which we need to consider that, and often there are now legislations which are there in different parts of the country itself, which really restrict any gender surgery without a detailed discussion. So we have to be very cautious. There are not only the psychosocial issues, there are also medical issues, medical legal issues, which are important, and generally deferring it for a later time will be quite important. Thanks a lot, Sajili, for the discussion. We will now move forward to the last talk, and that's a very, very important talk which is there today, is that with regards to the approach when gonadectomy is required, and that gonadal malignancy risk becomes extremely important to really identify, and when to think about that, how to manage, and that. We'll just see if there are any questions till now. We are very sorry that in the initial phase, the questions, Sajali, you can switch off the your screen. Okay, so before we stop off with this, we'll take a few questions. We are very sorry for the fact that there was some confusion with regards to questions. Now you can post all the questions and we'll answer that one by one. So the first question which is there is from Dr. Sarah, who is asking about for SLO, can we directly test for cholesterol level due to easy availability? Exactly. And that's why lipid profile is extremely important. If you look at our approach pathways for lipid profile, we do talk about, for the adrenal insufficiency, we do talk about the lipid profile as an important test, and that's extremely important in that regards. Dr. Akkarichuk is asking about a newborn presenting with ambiguous genitalia with ovaries and uterus, having no androgen exposure and normal 17 OHP levels. Okay, very interesting case. This is basically a DSD with definite Mullerian structures there. I assume that there are no gonads, so this looks like a XX DSD. We have got normal 17 OHP, so CAH 21 hydroxyl is off. 11 3 beta POR are unlikely. No androgen exposure. My first take would be aromatase deficiency to think of in that setting. The second thing which I'll probably think of would be gonadal dysgenesis. So we have to do those genetic tests. But before that, aromatase would be the most likely situation in that regards. Dr. Deepa is asking from Trishur regarding which all XY DSDs can present with a pseudo-vagina. Now, what we need to understand is that what really is pseudo-vagina. When we say pseudo-vagina, it basically means that the Mullerian structures are not there. So the upper 2/3 of the vagina is not developed, the lower 2/3 is there, which basically means that if you have severe testosterone deficiency or resistance of any cause, in which what we earlier used to call as sex reversal, will present with pseudo-vagina. So if you have your complete androgen insensitivity syndrome, they can present like that. SLO can present like that. So anything where you have zero androgen effect, they will present with that pseudo-vagina. So I think this is an important concept to think of. So if you want to now put questions, it's working. All of you can just ask questions in that regards. We'll now invite Dr. Pratik, who will basically be talking about the gonadal malignancy issues, when to think about it, how to evaluate, how to manage, and that is an extremely important topic to focus out in that regard. So Dr. Pratik, you can start off and from here.
So thank you very much, sir. Today's presentation, I will be presenting about the various gonadal malignancies in the disorders of sexual differentiation. I have divided my presentation into the introduction, pathophysiology, risk factors, etiology, management, and follow-up of these patients. Now, beginning with the introduction. So, why are we discussing this? Gonadal tumors comprise an important clinical problems in the individuals with these disorders of sexual development. Conventionally, it was considered that all 46XY DSDs who have a gonad have to be removed. But now this is slowly moving towards a more holistic approach where we consider the testicular function, the psychosocial aspects, and various other aspects and take a final decision rather than just doing a blanket therapy. We have to appreciate that there is a lack of safe and well accepted guidelines where these gonadectomies and the timing of these gonadal surgeries come into picture. But scattered reports and various surveys and various reviews have been done from which I've taken my information from. So beginning with the pathophysiology, I think this has been very well discussed previously. So the germ cell development is a highly complex process requiring alignment spatially, temporally, and genetically. So it all begins with the specification where the ordinary various other cells, they form the primordial germ cells. These are different from other types of cells. They are highly pluripotent cells. And then another influence of various factors, they then migrate from the epiblast to the genital ridge. This is mostly derived by the KIT and the KIT ligands. Now, even during this migration, they may stray off to other parts of the body, and if they are active over there, they might lead to formation of germinomas. But apart from that, when they reach the gonadal ridge, they are still not mature cells, and they are therefore called gonocytes or oogonia, which are the precursor cells. Following this, there is the sex determination, and in the presence of SRY, SOX9, or NR5A1, they form the testis. And in the presence of beta-catenin or FOXL2 or RSPO1, they form the ovary. Now, coming to the most important part, the gonadal tumors. These gonadal tumors can be classified as seminomatous or non-seminomatous tumors. Seminomatous tumors contain neoplastic cells which are arranged similar to gonocytes, which I had mentioned in the previous slides. So, if these tumors arise from the ovaries of the dysgenetic gonads, these are called dysgerminomas. The same tumor, if it arises from the testis, is known as a seminoma. As I had mentioned, if they stray off to other parts of the body in extragonadal locations, these are called germinomas. Non-seminomatous tumors include teratoma, yolk sac tumors, choriocarcinoma, and embryonal carcinoma, but we will be focusing more on the seminomatous as there were higher incidence in these gonadal tumors. Now, apart from this, what is the gonadoblastoma, which we most frequently discuss, or germ cell tumor in situ? So, gonadoblastoma is nothing but a precursor to all the neoplastic or the malignant tumors. It is now hypothesized that it has a fetal defect. So, it is probably present when the infant is born, and it increases in size when the age increases. And histologically, it contains all the germ cells. So, it has a germ cell lineage, it has sex cord cell lineage similar to the Sertoli cells or granulosa cells, and cell nest similar to the Leydig cells. Now, very importantly, these are not malignant. These are benign tumors and they do not metastasize. But few scattered studies, like one study mentioned that all gonadoblastomas has a 50% chance of developing into a neoplastic tumor, and all GCNIS. Now, I want to tell you that gonadoblastoma and GCNIS are almost the same. Gonadoblastoma occurs in the dysgenetic gonad or the ovary, and the GCNS occurs in the testis. That's it. So, but the GCNS has a 100% chance of becoming into a malignant tumor, but gonadoblastoma has a far lesser chance into becoming neoplastic. A very peculiar concept over here is, although some of them may occur bilaterally, but most commonly these are found on the right side. Now, coming to the dysgerminoma. This dysgerminoma is a far more sinister pathology. These arise from the ovaries or dysgenetic gonads, and as I had mentioned, if they combine from the testes, they are known as seminomas. Similar to the gonadoblastomas, they do have germ cells, but what separates them from the gonadoblastoma is the presence of T lymphocyte infiltration, anisokaryosis, and high mitotic rate, which increases the malignancy, and hence they are malignant. They're highly malignant and they spread to lymphatic spread and bony mets, and 90% of them are unilateral. Now, what about the non-seminomatous tumors? Yolk sac tumors or endodermal sinus tumors, these are highly malignant, do alpha-fetoprotein as a marker, and these can be found in dysgenetic gonads. Struma ovary, a very interesting concept. These tumors have thyroid-producing cells and can be a cause of thyrotoxicosis in individuals. And embryonal carcinomas can cause precocious puberty. Now, coming to risk factors. The most important risk factor for all these tumors is the presence of a Y chromosome. The gonadoblastoma Y region or the GBY region, which encodes the TSPY, the testis-specific protein Y encoded. This is a very high and potent risk factor for formation of these germ cell tumors. The formation of these germ cell tumors is proportional to the amount of mosaicism and also to the presence of masculinization. So the more the masculinization, more the risk factors. As this is mentioned before, higher the location of the gonad, more the risk of the tumor. So abdominal, more than inguinal, more than scrotal. Androgen receptor, high androgen levels as well as potent androgen receptors had a high risk of these tumors. As we can see in CIS, even though there are very high levels of androgen levels, but the androgen receptor is not working. So the per se risk of gonadoblastoma in them is very less. And other genetic factors such as POU5F1, which is a marker for pluripotency present in the germ cells, and other genetic factors such as WNT, RSPO1, etc., can be used as markers or risk factors for these tumors. Now I've combined etiology and management together. So let's go by etiology one by one. Coming to first, the pure gonadal dysgenesis. These occur due to underformation of the gonadal structure. Either you have a defective migration, or you have impaired organization of the gonadal ridge, or structural and numerical chromosomal abnormalities like Klinefelters or Turners. Complete gonadal dysgenesis, you will, for example, the Swyer syndrome, which is XY complete dysgenesis, complete female, or a partial gonadal dysgenesis, where the clinical features depend on the testicular function ability. The high risk of tumorigenesis can be predicted by the presence of a Y chromosome and the location of the gonads. So when we come to a partial gonadal dysgenesis, if it's a male phenotype, we can observe the patient and we have a low threshold for gonadectomy if the testis is non-scrotal, if there is ambiguous genitalia and reduced testicular function. If we have partial gonadal dysgenesis male with a fibrotic or streaked gonad, it is better to do an early gonadectomy. However, if the same male has a dysgenetic gonad, so it is better to do an orchidopexy, but our job doesn't end there. Orchidopexy merely brings down the tumor risk mildly, and that tumor gonad still has a risk of gonadal tumor, so we need to observe that gonad. And in complete gonadal dysgenesis, we are rare as female. It is better to do an early bilateral gonadectomy because there's high risk of virilization as well, and the high risk of gonadoblastoma in abdominal gonads. Coming to mixed gonadal dysgenesis, there's a 20 to 25% tumor risk. So in females who are rare as females, better do an early gonadectomy to rule out risk of virilization. Streaked gonads or fibrotic gonads, do a gonadectomy. Same as previous, male but dysgenetic gonad, better to bring it down. Now, one important factor in mixed gonadal dysgenesis is the presence of ambiguous genitalia, and if it's an infant. We cannot take hasty steps here, and it is better to wait and watch till the child develops a gender identity and then taking a further call. Now, coming to Turner syndrome, we know that the presence of Y chromosome increases the tumor risks about 33%. And it has also been seen that even if we have a negative XY in the presence of karyotype, PCR can show 5 to 10% risk, 5 to 10% Y chromosome in those who are karyotype negative for Y. Hence, so if you have a Turner syndrome with Y chromosome, do a prophylactic gonadectomy. But you have a marker chromosome. Now, various authorities are split on this condition. Some say you do an early gonadectomy, some say you wait and watch. So what is preferred here? You do a gonadectomy and do oocyte preservation, but be on a lookout for Y material and virilization, which is high risk, and you should do it immediately at that time. Now, coming to the various insensitivity syndromes, beginning with the complete androgen insensitivity syndrome. As I explained earlier, the tumor risk is very low, around 0.8 to 2% in prepubertal individuals and 30% in adult individuals. Now, there are various advantages of actually retaining the gonad, such as improved adult height and higher bone mineral density. So in CIS, it is suggested that in childhood, you look at the gonadal location. If it is abdominal, inguinal, per se does not require any management, and management is only required if it is causing any mechanical abnormalities. In adolescence or adulthood, it is very important to explain the patients the pros and cons of gonadectomy. So the pros include, there is per se, we don't have any proper surveillance technique to rule out any GCA, NIS, and there is a risk of 10 to 15%. But on the other hand, there is a risk of progression from GCA. GC is very low. And if we remove the gonad, there's a risk of high dependence and lifelong dependence on HRT. So after explaining this, if the individual opts for surveillance, you tell him or the individual to advise monthly self-examination of the gonads, and we can also use various markers. And if the individual opts for gonadectomy, go ahead with it. When it comes to partial androgen insensitivity syndrome, the tumor risk is high, and especially in non-scrotal gonads, as discussed earlier, it is 50% high in non-scrotal gonads. So in these cases, if it's a childhood problem in partial PAIS, we have to explain to the child and we have to explain to the parents about the condition. Now, if it's a male and if there's non-scrotal testis, you do an orchidopexy as early as possible and follow up this testis. Do the markers, advise monthly evaluation. If it's a female, abdominal, inguinal, or lingual gonads, no action needed unless and until there is any mechanical problems. And if in this individual you see virilization happening, it is an indication for gonadectomy. When we come to adulthood, it is very clear. You have to explain to the patients about the female or the male, and based on their call, whether surveillance or gonadectomy has to be done. The pros and cons, as I had explained earlier, can be explained to the individuals. Now, one important factor here is that 18 to 20, we can consider a gonadal biopsy for the detection of GCNIs. Rest, everything is the same as CAIs. The testosterone biosynthetic defects, as explained earlier, do have a risk, but they're relatively lesser than all the gonadal dysgenesis and the AIS. The Smith-Lemley opiates, according to whatever reviews I had read, only 2 reported cases are there and only query coincidental. A CAH such as STAR, SCC, they have a low risk of gonadal tumor, less than 5%. Now, 17 beta HSD has almost 30% risk of GCT. So if there are phenotypic males, you do close monitoring. As I'd explained, they are not free from the tumor risk, so you need to keep monitoring. If it's a female, you have to do gonadectomy to prevent further virilization. Now, 5-alpha reductase, phenotypic males do an orchidopexy, females do gonadectomy to prevent virilization. 17-alpha hydroxylase, 17-lyase per se has very limited data, and there is no clear evidence to do any gonadectomy. So summarizing what I have just told right now, the individuals at high risk for tumor risk include, first of all, the gonadal dysgenesis with an intra-abdominal gonads, Fraser syndrome, Dennis-Drash, PAIS. Now, if you notice here, the high-risk ones are the ones who have an intra-abdominal gonads. And the same individuals with the scrotal gonads come down in the risk of tumorigenesis. Hence, in those individuals, it's better to do a gonadectomy. In the intermediate risk, you can monitor. And there's almost 5-alpha reductase, as mentioned, there's almost less to no risk of gonadectomy, so you can be status quo. Now, coming to the follow-up of these individuals, how do we do this? Self-examination, boys with DSD and scrotal testis need to be shown how to do monthly evaluation of the scrotus. So any change in consistency, size, shape, or any feeling of any bumps or lumps, come to the doctor immediately. Imaging, ultrasound is a very important tool in scrotal and inguinal gonads. It is important in annual follow-up. The presence of microlithiasis is a very sensitive tool to look for any tumorigenesis, but it's not very specific. MRI can be used in pre-op planning to locate intra-abdominal gonads, but unfortunately, none of these techniques are recommended for monitoring the dysgenetic intra-abdominal gonad. Now comes the role of the biopsy. So it has its advantages and limitations. The advantages include early diagnosis and monitoring of tumor development. But however, the limitations are far more, that the gonadal tumors may be missed on biopsy. Initial normal lesions might be, on further biopsies, might become to a positive as a pre-malignant lesions. There are no prospective studies, and there is very limited evidence for the usefulness in female or ambiguous genital types. So per se, the gonadal biopsy is still a question mark to be done or when to be done. So the basic take-home messages include prophylactic gonadectomy is still a matter of debate. Management is not just a blanket 46XY do a gonadectomy. You have to take in various multiple factors. And most importantly, the patient should be fully informed and involved in the decision-making process before doing anything.
Thanks a lot, Pratik, for this very nice introduction discussion that we had with regards to different aspects of evaluation and management, and particularly the issues which probably are very, very relevant to have been discussed well. So what we've tried to do through this iDSD is that we started off with very basic pathophysiology. There's a huge development which has happened in this field, and we have looked into each and every aspect of newer genes, newer understanding of hormones. we switch forward to the newer classification, individual XX, XY, and a sex chromosome DSD. Then with regards to the approach, the evaluation, then the management, gender of rearing, and of course, very importantly, which Pratik now talked about, gonadectomy, which is a very important, crucial aspect in that regards. So we have already covered most of the questions. If there are any questions, we can look into that now. And if there are no questions, you're free to basically put your question and queries through the mail, and that will also be something which we like to have on that regards. So if there are any more questions, Nikhil? So if there are no more questions, we'll probably like to maybe stop at that point of time. Thank all of you for patient hearing. Thanks to Dr. Chetan, Dr. Riddhi, Dr. Neha, Dr. Sajari, Dr. Pratik, Nikhil, for the entire team for making it possible to have this discussion on that. And we'll try to post them up on the various links in our website from where you can access that from that regard. So once again, thanks a lot, everybody. And we're planning a couple of more activities. Probably we will have one on Turner syndrome somewhere around later this month, and then we'll go forward from there. And